dentistry, allied health sciences, public health, health professions education, community health, and the arts, natural and social sciences. The competency-based curriculum makes it stand out among the other schools. Since 2014, in compliance with the Philippine Qualifications Framework, the colleges are now transitioning to outcome-based education, or OBE. It enables the well-rounded development of students and unlocks their full potential as both health professionals and dedicated Filipinos. UP Manila educates the brightest students in the health professions and allied social science disciplines. Its students consistently top licensure examinations and assume positions of leadership and influence in government, the private sector, academe, non-government sector, and the community, giving them opportunities to shape national policies and programs on health. UP Manila is a pillar in the field of health research. UP Manila ensures that its faculty, staff, and students engage in research as a tool for health reforms to enhance education and complement its public service role. With the help of the National Institutes of Health, the center of and coordinating body for all researches in the university, UP Manila's researches have served as basis for national policy formulation and program planning. UP Manila's firsts in health research and policy include Republic Act 9288, the Newborn Screening Act of 2004, RA 9709, Universal Newborn Hearing Screening and Intervention Act of 2009, RA 10747, Rare Disease Act of the Philippines in 2016. Other advocacies include the studies on liver diseases that led to the mandatory vaccination of newborns against hepatitis B, commercialization of Lagunti and Sambong as proven effective medications for cough and colds based on the results of the National Integrated Research Program on Medicinal Plants, the Ventilator Project, and the Vision Screening Project for newborns and school children, all of these for healthcare improvement. Strengthening this role is its public service function rendered through the Philippine General Hospital, its community and volunteer programs, and scholarly and technical assistance to the government, private sector, and civil society. As the Philippines' biggest government and tertiary hospital, the PGH sees more than 500,000 patients a year from all over the country. It trains thousands of health students and health professionals from within and outside the university. Among its innovative programs are on child protection and poison control and management. Volunteerism is strong at UP Manila. From the very beginning, students are ingrained with their role as public servants. Through the ugnayan ng pahinuod, faculty, students, staff, and alumni volunteers provide health and socio-cultural services that benefit depressed communities and indigent Filipinos. And to further reach out to the larger society, UP Manila offers the Community Health and Development Program and other community-oriented programs. This combination of excellent education, relevant research, and public service has produced thousands of exemplary doctors, nurses, dentists, pharmacists, public health experts, rehabilitation workers, paramedical workers, and more. With more than 100 years of excellent leadership in health, UP Manila is keeping itself nationally relevant and globally competitive by being at the forefront of Philippine health. The challenge may change, but UP Manila's response will be certain, excellent, relevant, and transformative. The University of the Philippines. The only Philippine university to be named in the top 100 universities in Asia. This state-run institution is a paragon of education steeped in history and culture. The University of the Philippines system is composed of 8 universities around the country. The oldest of which is the University of the Philippines, Manila, the birthplace of the UP system in 1908 in Padre Faura Ermita. Its oldest unit, the Philippine Medical School, later renamed to UP College of Medicine, opened in 1905, followed by the Philippine General Hospital in 1907. From the College of Medicine evolved other colleges and units that diversify the university's course offerings. In 1948, UP was transferred to Diliman, Quezon City, leaving behind some health colleges and the College of Arts and Sciences. In 1976, the School of Health Sciences was created in Leyte to offer a community-based, ladderized health education that aimed to help increase the availability of trained health workers in the province. 2 satellite campuses of the school were strategically set up in 2 other remote and underserved provinces, namely Baler Aurora and Coronadal, South Cotabato. The creation of the Health Sciences Center in 1977 brought together all the health units under one roof. The center was renamed to UP Manila in 1983. Today, UP Manila is the recognized pioneer and leader in health education, research, and public service in the Philippines. Among its pioneering programs are university-wide BS Nursing, Master of Arts in Nursing, PhD Nursing, Master of Health Professions Education, Integrated Arts and Medicine, degree programs in Public Health, MD PhD, MA Health Policy Studies, MS Health Informatics, MS Genetic Counseling, PhD in the Health Sciences by Research, and the only ladderized midwifery, nursing, and medicine degree program of the School of Health Sciences. UP Manila's credentials have led to its being the partner of choice of the World Health Organization, Department of Health, Department of Science and Technology, Commission on Higher Education, and other local and international groups to achieve health reforms. UP Manila is the only campus in the UP system that offers education, research, and training in a wide array of health disciplines and professions. The university offers courses in medicine, nursing, pharmacy, dentistry, allied health sciences, public health, health professions education, community health, and the arts, natural, and social sciences. The competency-based curriculum makes it stand out among the other schools. Since 2014, in compliance with the Philippine Qualifications Framework, the colleges are now transitioning to outcome-based education, or OBE. It enables the well-rounded development of students and unlocks their full potential as both health professionals and dedicated Filipinos. UP Manila educates the brightest students in the health professions and allied social science disciplines. Its students consistently top licensure examinations and assume positions of leadership and influence in government, the private sector, academe, non-government sector, and the community, giving them opportunities to shape national policies and programs on health. UP Manila is a pillar in the field of health research. UP Manila ensures that its faculty, staff, and students engage in research as a tool for health reforms, to enhance education and complement its public service role.
Welcome to the third Patient Safety Congress, organized by the University of the Philippines, Manila. Please be reminded of the following rule. Please be reminded of the following rules. This event is being. You may type your questions in the Q&A box at any time during the lecture. The meeting facilitator will take note of them for discussion during the Q&A session. Kindly revise your name to include your institution. An example for renaming is found here in the slide.
Good morning to our participants and guests. We will now begin Day 2 of the Congress with a recap of Day 1 by Dr. Paul Michael Hernandez and Dr. Carl Matthew Sisu.
Good morning. We thank you once again for joining us on the first day of the third National Patient Safety Congress. Here are the highlights of yesterday's sessions. The first simultaneous session focused on implementing occupational health and safety standards for health workers. Under the executive or leadership track, the right to a safe and healthy workplace is a basic human right. We must all work towards enabling everyone to enjoy this fundamental right. Patient safety is dependent on healthcare worker safety, necessitating the need to maximize and integrate the synergies on patient and worker safety. Occupational health and safety should be integrated in all policies and programs of institutions. This should include clear policy frameworks and targets for monitoring performance in OSH. For the clinical track, neither a one-man show nor a silo mentality will promote workplace safety because it is a shared responsibility. Interprofessional collaboration does not only improve patient safety, but also enhances workplace safety. Medication use is a complex process that involves multiple healthcare professionals working together to ensure that safe and quality medications are administered to the patient. A medication safety use program should therefore be comprehensive and collaborative, which includes risk assessment and management to ensure patient safety, as well as initiatives to promote and ensure safety of healthcare workers. Effective communication among partners from public and private sectors and patients is key to success of any healthcare initiative. Quality service combined with passion, genuine compassion, and commitment is not only a good business practice, but more importantly, results in increased client satisfaction. Finally, for the innovations or education track, the way forward in achieving compliance with OSH standards and health worker safety includes effective intersectoral collaboration, efficient implementation of OSH law, and the promotion of a positive workplace culture in all health facilities. Successful capacity building to ensure occupational health and safety in health facilities involves good planning, an open communication, and monitored and evaluated implementation. To overcome challenges in implementing OSH standards, one must have the mandate, select the right people for the job, do the most one can, and persevere. Moving on to the second simultaneous session, which focused on protecting and promoting equity in health workers. For the executive or leadership track, we learned there are international and local guidelines to address workplace violence, SARS-CoV-2, and ergonomic risk factors in the health sector. Workplace interventions should be developed collaboratively with focus on the health workers. Monitoring and evaluation are key in improving workplace interventions to address workplace violence, SARS-CoV-2, and ergonomic risk factors in the health sector. The clinical track emphasized the following. Telehealth has safety risks to both the patient and the healthcare provider brought about by technology, the environment, and the system. It is a tool, not a goal, and it needs to solve a real problem. Medicine is still about people, patients, quality of service, and processes. In primary care, the relationship between the clinician and the patient is the key to high quality, safe, and effective health care. Patient safety can be improved by addressing numerous issues that occur when patients move between primary and secondary care and through patient and family engagement. Lastly, safety issues in psychiatric care includes violence and aggression, patient victimization, seclusion and restraint, suicide and harm, fall and other patient accidents, absconding and missing patients, adverse medication errors, adverse diagnostic events. To address patient safety concerns in mental health, adverse events, service availability, and quality care should be assessed. In the innovations or education track, we found out the following. Healthcare workers in the Philippines experience disparities in inequities in working conditions, benefits, and remuneration in the public versus private versus overseas work. There is a need for the whole of system approach in addressing these complex problems. Tracking university graduates, clarifying issues related to return service agreement, and partnering with other local and international institutions through organizing international conferences and research collaborations are key to developing a sustainable workforce. Lastly, social innovations that employ participatory, multisectoral, and multidisciplinary approaches in addressing systemic health challenges. For instance, democratization of admission to medical school or the School of Health Sciences provide greater opportunity for marginalized students to become health professionals in the future. Selection of students to be admitted should start from the community or the barangay, thus meeting the concerns of local people better. All these just on day one. Please join us again on the second day of the third National Patient Safety Congress as we focus on synergized approach to patient and health worker safety. Once again, good morning and thank you very much.
Good morning. We will now start the oral presentations of abstracts. In the interest of time, we will forgo the open forum at the end. However, our presenters will gladly answer your queries in the Q&A box, as well as leave their email addresses for further comments. So without further ado, presenting the abstracts of the clinical track. Psychological distress coping mechanisms with work satisfaction of nurses in a specialty hospital during the COVID-19 pandemic. Andrea Elaine Ventura.
Good morning, everyone. I am Andrea Ventura from Children's Service Ward, and on behalf of the Pediatric Research Team, I will be presenting our study entitled Psychological Distress, Coping Mechanisms, and Work Satisfaction Among Nurses of the Philippine Heart Center during the COVID-19 pandemic. As of the current situation, the COVID-19 pandemic is the most critical problem the world faces. Recent studies show that nurses are the most vulnerable to contracting the virus since they are at the forefront of patient care. The general objective of this study is to determine the significant relationship between the three aforementioned variables. Meanwhile, the specific objectives of this study are to determine the levels of psychological distress, coping mechanisms, and the degree of work satisfaction. The study also aims to establish significant relationships coinciding with each of the given factors. Let us discuss the methodology which indicates the use of descriptive correlational research design in determining the relationship between the three variables. The researchers utilized 3 open access questionnaires, including the Expanded Nursing Stress Scale, the Brief COPE Inventory, and the Mueller-McCloskey Satisfaction Scale. The research population included 116 qualified nurses based on the inclusion criteria: staff nurses on active duty from critical and non-critical units, staff nurses with at least 6 months of bedside care experience, staff nurses providing direct care to COVID-19 patients, and staff nurses from specialized care areas such as the emergency room, operating room, cardiovascular laboratory, and renal section were excluded from the study. The following considerations were strictly observed. Moving on to statistical treatment and analysis, the sample size of 113 was determined using G-power. For normally distributed variables, mean and standard deviation were used, while the Pearson correlation coefficient was used to determine relationship between variables. To summarize the results, there is an increase in psychological distress and coping mechanisms among nurses of the Philippine Heart Center during the COVID-19 pandemic. Consequently, a significant relationship was proven between the two variables as evidenced by a p-value of less than 0.001. In addition, an inversely proportional relationship was found between psychological distress and work satisfaction. In conclusion, nurses' psychological distress and coping mechanisms were increased due to the physical and psychological threats posed by the COVID-19 pandemic. However, despite this elevation, most nurses agree that they are satisfied with their work. Their adaptiveness and resiliency during the COVID-19 pandemic are significantly present and proven in this study. The following steps can be suggested based on the findings of this study. For government and lawmakers, free psychological consultation and counseling can help nurses cope with the effects of the COVID-19 pandemic. Creating policies and laws that will provide sufficient employee benefits for healthcare workers will also be beneficial. For the nursing service too, integrate a psychological section in the Holistic Wellness Development Program, enhance the education of healthcare workers on psychological well-being through live or recorded courses and trainings, and create a formal psychological wellness program that includes activities that foster the verbal and nonverbal expressions of feelings and thoughts. And lastly, for future researchers, obtain a larger number of respondents to facilitate a deeper study and to obtain various factors experienced by the healthcare providers in their respective workplace. Thank you and stay safe.
Pharmacists and consumers, perspectives in rendering clinical pharmacy interventions in the community pharmacy practice. John Rafael M. Jimenez.
And I'm going to present to you my research entitled Pharmacists and Consumers' Perspectives in Rendering Clinical Pharmacy Interventions in the Community Pharmacy Practice. Pharmacists by profession are mainly focused on the dispensing and compounding of medications. Community pharmacies have been caught up in the paradigm change in pharmacy practice. The patient-centered pharmacy practice that embodies pharmaceutical care was the way of the future. The pharmacy practice has shifted from a drug-specific model to a patient-centered model of care aiming to improve the patient's quality of life with minimal healthcare cost. The notion of application of clinical pharmacy in the community setting was elated from good pharmacy practice established jointly by International Pharmaceutical Federation and World Health Organization in 2011. Pharmacy practice aims to improve consumers' health by assisting them by providing quality pharmaceutical care through the safe and rational use of medicines. The study aims to provide community pharmacists evidence with adequate sample size and strong statistical power of introducing and rendering clinical pharmacy services in the community pharmacy setting and to support accelerated intervention for approval and implementation. The quantitative study was done through a validated self-administered questionnaire distributed among community pharmacists and consumers to determine their perspective and perceived barriers in rendering clinical services among the community pharmacies. Table 5 presents that the perception of community pharmacists in rendering clinical pharmacy services in the community pharmacy setting. Results revealed that the community pharmacists have a very high positive perception of rendering clinical pharmacy interventions in the community pharmacy, obtaining a weighted mean of 4.15. Concerning about the perception of consumers were measured in rendering clinical pharmacy services were presented here in table number 6. Results reveal that consumers have a high to extremely high perception in rendering community-based clinical pharmacy interventions within the basic unit of society. With a given traditional setup of pharmacies in the Philippines, the concept of rendering clinical pharmacy services within the community pharmacy setting is far from homogeneous. Results showed the barriers in rendering clinical pharmacy services in the community pharmacy setting perceived by community pharmacists and consumers. Results revealed that the most common barriers were lack of support by the government, lack of support by other health professionals, and patients' lack of awareness regarding the wide range of knowledge that pharmacists able to answer such drug and drug-related queries. Thus, the role of community pharmacists has transcended beyond the idea of confining community pharmacists as the man behind the drugstore counters, providing dispensing, compounding, and counseling of medications. It is imperative that the role of community pharmacists has gradually extended from the traditional notion of product-centered service to the healthcare practitioner that provides rational pharmacotherapy and addressing medication-related problems and proposing solutions to the problem. In order to develop and maintain proactive role of community pharmacists, the researcher recommend that in order to increase the quality of healthcare services delivered, community pharmacist competency must be addressed or must be assessed by integrating competency framework to facilitate continuing professional development. Bringing this on a national level by developing stronger legislation, regulation, and implementation of the concept through setting standardized guidelines in the community pharmacy practice will be a rational foundation in establishing the best practice possible in delivering pharmaceutical care.
Perceptions of patients and on university-based drug information service on medication safety. Christine Eves Garcia.
Good day, I am Christine Garcia, and on behalf of the research team, I will present the study Perception of Patients in a University-Based Drug Information Service on Medication Safety. The current pandemic has prompted healthcare professionals to deliver healthcare services in alternative platforms. Among these, telepharmacy allows pharmacists to provide drug information services which can improve medication safety through detection of drug-related problems and implementation of telepharmaceutical recommendations. In line with this, the UPCP telepharmacy service was launched through Facebook last July 2020, targeting patients and their caregivers. The platform used to receive queries is a Google form, while responses were sent through text, messenger, or email. With the service being operational for 2 years, the study is being done to assess the perception of clients in a university-based DIS in improving their knowledge and decision-making that contribute to medication safety. Specifically, it aims to describe the characteristics of the clients that avail the service, their drug information needs, and level of satisfaction on the service. It also aims to explain how the service affected patient attitude towards medication safety and their health decision-making process. This quantitative cross-sectional study is conducted through calls to answer a guided questionnaire survey. Respondents of the study is based on the list of clients from the telepharmacy service database for the period October 2020 to July 2022. The following inclusion and exclusion criteria are used to determine the eligible clients. The initially computed sample size for the study is 218 respondents. An assumption of 25% non-participation increased the sample size to 273 participants. The study started on May 2022 and is expected to be completed by the end of the year. Now, for the implementation of the study, the research team started with the development of the data collection tool and informed consent form. Close-ended questions on demographic characteristics and drug information needs are asked, followed by statements on satisfaction, knowledge, decision-making, and medication safety to be answered using a Likert scale. The tool was developed in English, then translated to Filipino by the UP Sentro ng Wikang Filipino. Training of data collectors was done to ensure consistency of data collection and quality of data. Next, 30 respondents with similar characteristics as the actual participants were selected for pilot testing. Its results were used to check the internal consistency and reliability of the questionnaire. Simple random sampling is employed on the study population. Selected clients on the service are contacted to evaluate if they meet the criteria. Once determined to be eligible, they are asked for their willingness to participate in the study, and an appointment is scheduled to answer the questionnaire. During the set appointment, the respondent is asked to verbally give his or her consent, and once obtained, the data collector provides the submitted query and response given through telepharmacy to refresh their memory before proceeding to the questionnaire, which is read verbally to the client while the data collector encodes their response. All data collected will be validated by the research team using the recording to ensure accuracy. Now, for data analysis, the study will employ frequency and descriptive statistics to measure demographic characteristics, drug information needs, and satisfaction. Several statistical tests will be used as applicable to analyze the relationships among the variables. For ethical considerations, the study is approved by the UP Manila Research Ethics Boards prior to implementation. The Filipino translated ICF is read to the client at the start of the call. Also, a data protection plan is strictly implemented. The study is funded through the NIH UPM Research Grant 2022, and currently the study has completed its data collection and will now proceed with data processing. Thank you for your attention.
Effectiveness of central line maintenance checklist in decreasing the incidence of central line associated bloodstream infection. Rihanna Jean Maksapak, Diane Margaret Mangalili.
Good day, everyone. I am Rihanna Jean Makaspak, Nurse Manager of the Medical and Surgical ICU of Makati Medical Center. I will be discussing with my co-NM, Ms. Diane Margaret Mangalili, the effectiveness of central line maintenance checklist in decreasing the CLABSI incidences in the adult critical care unit. Healthcare-associated infections can have detrimental effects on patients' health and can prolong their hospital stay. One of the most common HAI is central line associated bloodstream infection, or also known as CLABSI. CLABSI is defined as laboratory confirmed bloodstream infection where central line was in place. All of HAIs, including CLABSI, can be prevented. Thus, creating a process is essential to avoid any occurrence of CLABSI. In September 2019, Medical and Surgical ICU created a checklist in order to prevent incidences of CLABSI, and it was implemented in October 2019. Prior the central line maintenance checklist, there were a total of 7 CLABSI cases, and from our investigation, the most common causes were prolonged utilization of the central catheter and multiple venues for central catheter manipulation. Thus, our objectives are to strengthen knowledge in the proper care of central line and decrease and prevent central line associated bloodstream infection incidents. The checklist is accomplished 2 times daily for all admitted patients with central line catheter. There are 14 critical steps indicated in this checklist. Each critical step serves as a guide in proper handling of the patient's central line catheter. These critical steps include performing of hand hygiene, reviewing of catheter necessity, monitoring for prolonged catheter use, adhering to disinfection protocols, and maintaining aseptic techniques. Any significant findings in any of these criteria are immediately addressed. Hi, I'm Diane Margaret Mangalili, one of the nurse managers of Medical and Surgical Intensive Care Unit of Makati Medical Center. To continue our presentation, let me discuss to you the results of the implementation of our project. The effectiveness of the Central Line checklist was measured based on the reported CLABSI events from 2020 up to present. As you can see, in 2020, there's a 55% decrease of CLABSI events in our unit. In 2021, there's 33%, and in 2022 year-to-date, there's 77% decrease, all compared to the 2019 data. In conclusion, there is a 77% decrease of CLABSI occurrence from the 2019 baseline data since the project was implemented. Also, interdisciplinary collaboration is necessary to increase its impact to healthcare outcomes and save patient costs. We'd like to thank Makati Medical Center, our former clinical department manager, Ms. Liza Marie Ballester, and our nursing quality officer, Ms. Danica Alcantara, for making the CQI project possible and successful. We would also like to thank the Patient Safety Congress for this opportunity to present and impart our project with the goal to achieve patient safety through hospital-acquired infection prevention. Thank you everyone and have a good day.
UPPGH Department of Anesthesiology Narcotics Disposal Algorithm. Mark Velasco.
Have you ever wondered what happens to excess or unused intravenous narcotics after a surgery? Unfortunately, the practice in our hospital is to waste unused IV narcotics in the sink or even keep them in syringes. Yikes! This is not environmentally friendly and even against the rules and regulations set by our local Dangerous Drugs Board. In fact, the environmental contamination by pharmaceuticals is a documented problem worldwide. Pharmaceuticals, especially narcotics, have been documented to leach into groundwater and contaminate drinking sources. Drugs such as propofol and morphine are considered toxic to aquatic life. During the COVID-19 pandemic, we also saw a shortage of sedative medications due to an increase in use, and this highlighted this environmental issue further. Moreover, improper wasting of IV drugs and narcotics pose a significant health risk to workers. As such, narcotics can be misused and mishandled, an all too important issue that should not be taken lightly. Realizing the importance of these issues, the UPPGH Department of Anesthesiology introduces the Narcotics Disposal Algorithm, or NARDA, a patient safety initiative. So what or who is NARDA? NARDA is a collaborative effort between the Departments of Pharmacy, Nursing, and Anesthesiology that aims to improve the practice of environmentally friendly and Dangerous Drugs Board compliant IV narcotics disposal in the operating room units of the PGH. With NARDA, we hope to accomplish three things mainly. 1. Ensure that all IV dangerous drugs in the OR are monitored and accounted for accurately and safely. 2. Provide a reliable disposal method that is compliant with the regulations set by the DDB and integrate with the existing waste disposal system of the hospital. And lastly, make the process as simple and easy to do to improve compliance among anesthetists, pharmacists, and nurses. NARDA entails a simple 4-step process that is acquire, witness, dispose or return, and document. Instead of just telling you, we'll show you how the process works. First is to acquire the medications. This is where anesthesiologists retrieve their narcotics medication kit at the start of every surgical case. After the surgery is concluded, next is to witness. The OR nurse notes the remaining unused IV narcotics after the case. Depending on the alert classification of the IV drug use as shown here, we then proceed to either dispose or return. If it's a high alert drug such as fentanyl or ketamine, it is returned to the pharmacist. If it's another non-high alert dangerous drug such as propofol or succinylcholine, it is wasted directly into biohazard bins as witnessed by nurses. Last step is to document, wherein the pharmacist, anesthesiologist, and nurse document and sign the return slip for drugs and supplies, ensuring that the acquired matches the unused and wasted volume. This is just to show the official return slip form used where pharmacists, anesthetists, and nurses sign. So you must be wondering what happens to these medications after. For non-high alert dangerous drugs wasted or discarded into biohazard bags, the hospital's Office of Engineering and Technical Services has a contracted waste disposal management provider that facilitates thermal destruction of biohazard waste. This breaks down the IV drugs into inactive compounds, making it safe when returned to the environment. IV narcotics surrendered to the pharmacy, on the other hand, will be returned to the DDB facility in Quezon City for disposal in their own units. This is mandated by law. So far, NARDA has successfully improved efficiency, as evidenced by a 60% tracking system improvement from the pharmacists, and has also decreased environmental contamination and provided a safe working atmosphere for all OR personnel involved. In summary, we emphasize three things. One, that environmental protection is a health concern that is usually neglected, but should actually take a bigger role because of its wide and far-reaching impacts on health and safety. Next is that the teamwork dynamic between all health professionals is a must in providing safe, simple, and effective means to improve IV narcotics disposal. And last, safety for all, yes, including us healthcare workers, is of paramount importance in fostering a healthy work environment. NARDA is not just one person, but rather a collaboration. Thank you.
That concludes our presentation for the clinical track. Any and all questions left will be answered at the Q&A box will be answered later today. The outcome for the top abstracts will also be announced later today. Thank you for listening. We will now proceed with synchronous session 3.
Good morning, everyone. So just a reminder, you may send your questions through the Q&A box, and we will gladly send that to our oral presenters this morning. Thank you very much.
You may visit our website for session recordings, oral, and poster presentations. Please also access our Facebook page and vote for your favorite advocacy video. You may visit our website for session recordings, oral, and poster presentations. Please also access our Facebook page and vote for your favorite advocacy video.
The University of the Philippines, the only Philippine university to be named in the top 100 universities in Asia. This state-run institution is a paragon of education steeped in history and culture. The University of the Philippines system is composed of 8 universities around the country. the oldest of which is the University of the Philippines, Manila, the birthplace of the UP system in 1908 in Padre Faura Ermita. Its oldest unit, the Philippine Medical School, later renamed to UP College of Medicine, opened in 1905, followed by the Philippine General Hospital in 1907. From the College of Medicine evolved other colleges and units that diversified the university's course offerings. In 1948, UP was transferred to Diliman, Quezon City, leaving behind some health colleges and the College of Arts and Sciences. In 1976, the School of Health Sciences was created in Leyte to offer a community-based, ladderized health education that aimed to help increase the availability of trained health workers in the province. 2 satellite campuses of the school were strategically set up in 2 other remote and underserved provinces, namely Baler Aurora and Coronadal, South Cotabato. The creation of the Health Sciences Center in 1977 brought together all the health units under one roof. The center was renamed to UP Manila in 1983. Today, UP Manila is the recognized pioneer and leader in health education, research, and public service in the Philippines. Among its pioneering programs are university-wide BS Nursing, Master of Arts in Nursing, PhD Nursing, Master of Health Professions Education, Integrated Arts and Medicine, degree programs in Public Health, MD PhD, MA Health Policy Studies, MS Health Informatics, MS Genetic Counseling, PhD in the Health Sciences by Research, and the only ladderized midwifery, nursing, and medicine degree program of the School of Health Sciences. UP Manila's credentials have led to its being the partner of choice of the World Health Organization, Department of Health, Department of Science and Technology, Commission on Higher Education, and other local and international groups to achieve health reforms. UP Manila is the only campus in the UP system that offers education, research, and training in a wide array of health disciplines and professions. The university offers courses in medicine, nursing, pharmacy, dentistry, allied health sciences, public health, health professions education, community health, and the arts, natural, and social sciences. The competency-based curriculum makes it stand out among the other schools. Since 2014, in compliance with the Philippine Qualifications Framework, the colleges are now transitioning to outcome-based education, or OBE. It enables the well-rounded development of students and unlocks their full potential as both health professionals and dedicated Filipinos. UP Manila educates the brightest students in the health professions and allied social science disciplines. Its students consistently top licensure examinations and assume positions of leadership and influence in government, the private sector, academe, non-government sector, and the community, giving them opportunities to shape national policies and programs on health. UP Manila is a pillar in the field of health research. UP Manila ensures that its faculty, staff, and students engage in research as a tool for health reforms to enhance education and complement its public service role. With the help of the National Institutes of Health, the center of and coordinating body for all researches in the university, UP Manila's researches have served as basis for national policy formulation and program planning. UP Manila's firsts in health research and policy include Republic Act 9288, the Newborn Screening Act of 2004, RA 9709, Universal Newborn Hearing Screening and Intervention Act of 2009, RA 10747, Rare Disease Act of the Philippines in 2016. Other advocacies include the studies on liver diseases that led to the mandatory vaccination of newborns against hepatitis B, commercialization of Lagunti and Sambong as proven effective medications for cough and colds based on the results of the National Integrated Research Program on Medicinal Plants, the Ventilator Project, and the Vision Screening Project for newborns and school children. All of these for healthcare improvement. Strengthening this role is its public service function rendered through the Philippine General Hospital, its community and volunteer programs, and scholarly and technical assistance to the government, private sector, and civil society. As the Philippines' biggest government and tertiary hospital, the PGH sees more than 500,000 patients a year from all over the country. It trains thousands of health students and health professionals from within and outside the university. Among its innovative programs are on child protection and poison control and management.
Hello, good morning, everyone. Everyone and everybody. Okay, so I'm Dr. Connie Sison, and I'm a UPCM faculty of the Department of Pharmacology and the Department of Pediatrics. And I'm your session chair for this clinical track on ensuring psychological safety and well-being in the health workplace. So we have actually 3 exciting topics this morning. And so we'll go ahead and introduce our first speaker. Our first speaker who will talk on practical approaches in building a culture of safety is one of our professors in the UP College of Medicine. She is a multi-awarded teacher and a much-loved mentor in the UPCM and PGH. So she's one of those who got me interested in patient safety. She has held important leadership positions, including chair of the Department of Pharmacology and Toxicology of UPCM, head of the National Poison Management and Control Center of UPPGH, and president of the Philippine Society of Clinical and Occupational Toxicology. She is an expert in the field of family medicine, clinical toxicology, and patient safety. So please, let's give a warm round of applause for Dr. Lynn Crisanta Panganiban.
Good day, everyone. I'm Dr. Lynn Panganiban. Today, I will discuss practical approaches in building a culture of safety. I have no conflict of interest to disclose. So why the importance of a safety culture in an organization? Literature has shown that safety culture is considered to be a key strategy to strengthen and enhance patient safety and outcomes in hospitals. Thus, building a strong safety culture in our setting should be a priority. So this is the outline of my lecture. So let us revisit the definition of culture of safety. There are several definitions of culture of safety in literature, but these definitions would often mention values, attitudes, perceptions, assumptions, competencies, and patterns of behavior alongside employees or workers, groups, organizations, systems, and managements. Several authors would refer to certain aspects in the organization that shape the norms and values of such organization, and that these aspects are deeply rooted patterns that develop gradually through time. So personally, if you would ask me what definition of culture of safety I would prefer, I would lean towards a definition that was made by Bro Otto, and simply said, culture of safety is what is important, how things work, the way we do things around here. So if safety culture is a set of shared values, norms, behavior that makes up an organization, what compels us to adopt them? How do they develop through time? A review of literature done by Bisbee et al. In 2021 identified some factors in existing models and theories of safety culture that eventually would translate to the development of safety culture. The authors classified the factors as enabling factors and enacting behaviors. So enabling factors, as shown in the slide, set the conditions for individual workers to adopt assumptions, values, and norms consistent with safety culture. Now, the second set of factors is referred to as the enacting behaviors. So enacting behaviors, as shown here in the slide, would manifest the assumptions, the norms, and the values of the organization through time. Now, these behaviors will impact safety outcomes in that positive outcomes affirm existing behaviors, and the negative outcomes will challenge these behaviors. So with consistency and stability through time across workers, safety culture is developed, enriched, and reinforced. Developing a safety culture will require three ingredients. So one is to uphold enabling factors, as I have shown, that create conditions conducive for safe behavior, values, and assumptions. Two, for workers to observe and learn from consistent outcomes of their enacting behaviors. And three, the stability over time to allow the collective adoption of safety culture. So let me now discuss some approaches in building a culture of safety that have been found to be effective based on literature and my own observations. I have classified the approaches into three categories, namely firming the foundation, breaking the barriers, and bracing the bayanihan spirit. Under these approaches, I will present some strategies and activities. The bottom line of all these approaches and strategies is a healthy workforce in a healthy work environment, translating to better outcomes. So under firming the foundation, one strategy is the conduct of safety culture assessment. So the key reasons for safety culture assessment are the following: to diagnose safety culture and identify areas for improvement, evaluate patient safety interventions or programs, and track change over time, conduct internal and external benchmarking, and for fulfill directives or regulatory requirements. There are several tools that are being used to perform such assessment, but one that is commonly used is the Hospital Survey on Patient Safety Culture that was developed by the Agency for Healthcare Research and Quality. So as an example, let me share with you some patient safety culture data from 42 hospitals, which the Program for Healthcare Quality and Patient Safety of the UP College of Medicine generated in 2019. The team used the 12 composite questionnaire of AHRQ. So of the 12 composites, the composites with the 3 high scores, and these were considered areas of strength, were teamwork within units, organizational learning, and teamwork across hospital units. On the other hand, the composites with the 3 low scores and considered areas of potential for improvement were communication openness, non-punitive response to error, and staffing. So having recognized the areas of strengths and areas of potential for improvement, organizations are guided to hang on to their strengths and work towards changes with regards to the areas that would need improvement. The second strategy under firming the foundation is the conduct of leadership or executive walk-rounds, which has been reported in literature to show strongest evidence in improving safety culture. There are two objectives of safety rounds. One is to encourage the senior managers to engage with staff to understand their concerns. And second, is to partner with frontline workers and managers to resolve obstacles. But for safety walk rounds also to be effective, they should be followed by feedback. And this is to assure and show the staff that actions are being done with regards to their concerns. But there are instances where feedback is not done, and therefore this can create an atmosphere of uncertainty, disappointment, and frustration on the part of the staff. Thus, safety walk-rounds and feedback should go hand in hand. It has been shown that safety walk-rounds with feedback is associated with better patient safety culture, higher employee engagement, and lower burnout. Now, the third strategy under firming the foundation is continuous team education and training. This can either be structured or simulation-based and should include all members of the organization, including students. Such training activities should be multidisciplinary in nature. We have been used to the silo nature of our education and perhaps our work. Thus, we need to create activities that can develop a sense of unity, wholeness, and openness among healthcare workers. This can be in the form of case conferences, case management meetings, such as brown bag breakfast meetings, or audits that are participated in by all members of the healthcare team. Formal courses can be provided to healthcare workers. An example is the Team Steps Fundamentals course. In this regard, a team from the UP College of Medicine, the College of Nursing, and the Philippine General Hospital has been conducting this course since 2017 for healthcare providers in hospitals, professional societies, and associations in this country. Other trainings may include skills trainings such as ineffective response to medical errors, root cause analysis, among others. And a comprehensive unit-based safety program is also another initiative that can be done in this regard. Now, the fourth strategy under firming the foundation is the design and implementation of an efficient work processes. And this work processes should include simplification and standardization of all our work processes. And an example of which is the adoption of information technology such as the electronic medical records and the web-based systems for event monitoring, which I suppose many of us are engaged in at the moment. However, we also have to take note that efficiency and effective management of these electronic databases should also be attended to in order to prevent any forms of misuse or errors. Now, another strategy, or it can be an activity, is the development of information education campaign materials, for instance, for orientation and instruction purposes for patients and families. In the recent years, the nurses from the Philippine General Hospital have developed several materials in print and videos, which they have been using for these purposes. These have helped them manage their time when attending to patients, and this the improved efficiency will reduce pressures and demands in the workplace, and will hopefully address issues such as work overload. Now, moving on, there are two strategies I would like to share under breaking the barriers. The first one is enhancing teamwork and communication. So to recall, teamwork and communication are enacting behaviors and among the driving factors towards safety culture. So many published safety culture surveys done among Filipino healthcare workers showed high positive scores on teamwork, either within or or across units. Thus, we should encourage and enhance multifaceted unit-based programs, interprofessional committees and management teams, team building activities, and improvement of communication channels. So some examples of multidisciplinary teams are the clinical incident response teams, such as the brain attack team and the code team, and committees such as ORMAT, Therapeutics Committee, among others. Adopting the co-creation process is a way also of breaking barriers. In this process, workers, regardless of the position in the organization, meaningfully contribute to solutions to challenges and areas that need improvement. And so workers act together for a particular purpose. And this is done through co-designing and co-producing. So it is important that leadership needs to recognize the significant role of each worker and in the organization, and should involve the appropriate groups in the planning and decision-making processes. For the third approach on bracing the Bayanihan spirit, I will share 3 strategies. First is promoting a just culture, which may include creating policies on just culture, strengthening patient safety committee towards a learning culture, and the privacy and confidentiality safeguards. So while many of us may have adopted or are still adopting the reward and incentive model, we can move forward towards intrinsic motivation model, and this is presented and described in the IHI Psychology of Change framework to advance and sustain improvement. According to Dr. Deming, who was one of the pioneers on quality and safety in organizations, for us to improve, we must move from systems driven by fear and extrinsic motivation such as rewards and incentives to inherent motivation or intrinsic motivations, or areas that arise from motivations that arise from an environment of trust, relationships, interdependence, and pride in work. So according to the framework developed by the Institute for Healthcare Improvement, intrinsic motivation would refer to, and I quote, doing something for the inherent satisfaction that engaging in the activity provides. So I would think of this as discovering what is in there for me and what is important to me, and whether that what is important to me is taken into consideration when changes are made. And it also means taking up a sense of responsibility and participation in that how well the task gets done is up to me. So how can this intrinsic motivation be unleashed in an organization or each and every one of us? According to the framework by IHI, one way is the use of public narrative. And this public narrative consists of 3 elements: the element of self, and the element of us, and the element of now. Now, these 3 narrative elements establish a foundation within which an individual, team, or organization can lead on the basis of, number 1, the individual motivating values, and these are referred to as the stories of self. They can collaborate on the basis of shared values or the stories of us, and they can access sources of courage to respond mindfully to an urgent challenge rather than opposing or reacting to it, the stories of now. So these stories communicate the intrinsic motivations that will push or propel improvement efforts, such as dignity and respect, fairness and equality, justice and safety, and love and kindness. Now, the second strategy under the Bracing the Bayanihan Spirit is situation monitoring and mutual support. So situation monitoring means watching each other's back, and mutual support is the backup behavior in that we anticipate and support team members' needs through accurate knowledge about their responsibilities and workload. So currently, many hospitals and organizations have adopted several programs and activities as listed in the slide. So I do believe that organization has to have a strong program to improve healthcare team well-being. Otherwise, this will have some negative impact on patients' health and outcome. Now, the third strategy to bracing the Bayanihan spirit is improving joy in work. One of our concerns in the workplace that hinders the development of a strong culture is burnout. The Institute for Healthcare Improvement, or IHI, also developed a framework to address burnout and increase joy in work. It recommends domains such as recognition, choice, and autonomy, camaraderie, and teamwork, physical and psychological safety. What the document talks about what matters to you conversations that we can engage in with each other, especially leaders with other members of the team. And these are meaningful encounters to understand what matters to us in life, what helps make a good day, and what gets in the way of a good day. So this can assist us in addressing the deeper sense, in a deeper sense, the source of burnout and restore and improve joy in work. So this document, or the IHI document, provides what matters to you conversation guide, very practical guide that we can adopt in our own settings. So what are my takeaways from this lecture? So number one, organizations with strong workplace safety cultures were consistently associated with favorable patient outcomes. Safety culture consists of collective norms, values, assumptions that are developed gradually through time by multi-level influences. So this does not happen overnight. Approaches and strategies to promote the safety culture may include a single intervention or several interrelated interventions combined into a multifactorial approach. And approaches may focus on, as we have discussed, firming the foundation, breaking the barriers, and bracing the Bayanihan spirit. Thank you for listening. And again, good day to everyone.
Thank you very much, Ma'am Lynn, for that illuminating talk. I guess the realization is that we really need a safety culture to improve our health outcomes, but safety culture is hard work. And there are three ingredients, as you said, firming the foundation, breaking the barriers, and bracing the Bayanihan spirit. And there are strategies to achieve that. Just a reminder, we will entertain questions after all speakers have given their talk. So in the meantime, so that you will not forget your questions, please use the Q&A tab to type in your questions, and we will address them later at the end of the session. So speaking of communication and openness to build a safety culture, our next topic is speaking about patient safety. Our second speaker is an expert in cardiovascular nursing and critical and perioperative care. She is currently the chief of the Division of Critical Care and Specialized Care in one of the busiest hospitals in the country, and that's the Philippine Heart Center. She finished her Bachelor of Nursing from the University of the Philippines, Manila, and Master of Arts in Nursing, Adult Health Nursing at the Open University of the University of the Philippines, Los Baños, Laguna. She's the winning author of Increasing Patient Satisfaction Through Improved Communication Strategies, which was recognized by the Hospital Management Awards in Asia. Likewise, she is a recipient of the Healthcare Leadership Award for innovations in quality of service delivery. So I guess we're excited to see her and to hear her talk and to talk about, again, speaking up about patient safety. Let's give a warm round of applause for Marie Charisse Magallanes.
Good morning, ladies and gentlemen. It is my honor and privilege to be invited to the third National Patient Safety Congress with the theme Synergized Approach to Patient and Health Worker Safety. Speaking up about patient safety was a challenge among us health professionals during the previous years. However, the challenges in creating a voice towards the benefit of patients as well as healthcare workers had been drastically lowered recently in the advent of online technology, awareness of safety protocols, and implementation of programs that specifically increase the perception of the effectivity of speaking up. What's the deal with speaking up? Silence isn't safe. Speaking up is. Healthcare practitioners, especially frontline staff, are well positioned to observe unsafe conditions and bring them to the attention of those who can remediate them. However, no matter their position or specialty, most medical and nursing professionals have had some experience in hesitating with speaking up when they see a safety risk, even when morally obligated to report their concern. Previous research have shown that the choice of the healthcare worker to speak up can contribute to the prevention of adverse events such as medication errors, infection, wrong site surgical procedures, and other events. How do we define speaking up? Speaking up is the raising of concern by healthcare professionals for the benefit of patient safety and care quality upon recognizing or becoming aware of the risky or deficient actions of others within healthcare teams in a hospital environment. Speaking up cannot only be encouraged in a hospital environment. It should also be present in other healthcare settings such as rehabilitation facilities, nursing homes, and specialized outpatient centers such as hemodialysis centers, dental clinics, and chemotherapy units, to name a few. Why are we required to speak up? If you feel that there was a misdiagnosis because a certain laboratory result was not considered, or you are concerned about a rise in surgical site infections because hygiene protocols were violated by certain staff, you are uncomfortable because abbreviations were being used by certain doctors that's causing medication errors among nurses. Or you are frustrated because in your hospital, there are obsolete guidelines that are detrimental to patient, healthcare worker, or facility safety. Then it's time to speak up and be heard. Why is speaking up critical to patient safety? Keeping silent about unsafe work practices can be costly to the institution as well as to the patients. Not only it prevents safety-related incidences that increase hospitalization and subsequently its cost, but it also protects the hospital from further litigation or court settlements to address sentinel events. When employees are disappointed with the safety culture or the lack thereof, they tend to be dissatisfied with the existing work environment, causing them to resign, therefore causing further expenses for the hospital to train new staff and thereby increasing safety risks to the patients since the competency level of the personnel are now more on the novice side. Many major nursing organizations in Western countries are including speaking up as part of their code of ethics. Speaking should be done everywhere. According to the Agency for Healthcare Research and Quality, analysis of data from multi-set of patient safety organizations showed that 5.9% of events in ambulatory care units resulted in severe harm and 1.9% resulted in patient deaths. Medication-related events were the most common, followed by clinical deterioration and falls. Speaking up through the conduct of daily safety huddles, this short meeting presents an opportunity for staff to flag unsafe conditions and take proactive steps to solve situations. Commitment in safety to improve women's health care, most especially in childbirth, has been intensified also by our local specialty organizations. Speaking up should be encouraged in areas of patient assessment issues, selection and management of therapies, technical performance, and other related issues such as patient-doctor-nurse relationships and documentation. Pediatric safety-related events from the intensive care setting, ambulatory clinics, as well as convalescent floors include medication errors, falls, infections, and ventilation issues, to name a few. In the United States, the National Association of Pediatric Nurse Practitioners offered guidance on how to ensure the environment is a safe place to receive care. They mentioned that a behavioral expectation that supports a questioning attitude is necessary. When faced with questionable information, a healthcare provider should qualify the source of the information, validate whether it made sense to her, and check the information. If the worker is uncertain, he should take time to stop and review, assess, and resolve the uncertainty before getting further with care. In total, speaking up for patient safety is not limited into an area of practice, but should be taken up in the whole spectrum of healthcare. We review a case study from the Johns Hopkins Medicine. After finding out that one of their physicians had engaged in a serious misconduct, the Johns Hopkins Medicine sought to improve employee voice by commissioning a team of evaluators from Cambridge University to review the attitudes of senior leadership and frontline staff regarding speaking up. The first phase was to interview the staff, and the Johns Hopkins Medical were made aware of the barriers the staff faced when speaking up. Results revealed that the system for reporting was convoluted and confusing. The staff were worried about hostile responses from those senior or them being labeled as bad team player. The untouchables, those often senior physicians who engage in poor conduct, did not face any form of consequences. The evaluators interpreted the interview results that many of the Johns Hopkins Medicine staff worked in a culture of fear, wherein the personnel felt there were negative responses to speaking up and that nothing would be done about those who acted poorly. The interviews were done last 2014, and from there on until 2016, the leadership implemented interventions to address the concerns of staff and encourage speaking up. This included sharing the interview findings with the senior leadership, coordinating reporting systems, training leadership on how to handle difficult conversations, and ensuring that unacceptable behavior had considerable consequences. In addition, the Safe at Hopkins program was enforced to promote a culture of safety through prevention and early intervention in unprofessional and disruptive behaviors. This was designed to provide psychological safety to those who were speaking up and to those who were reported. The intervention had a positive impact on staff at Johns Hopkins Medical. During the study period, employees made 382 individual reports of disruptive behavior that led to 55 investigations in which officials interviewed an entire clinical unit. Most of the reported individuals were referred and provided with additional support. 9 of the reported individuals were eventually removed from their positions of power. Our second case study is in the Arkansas Children's Hospital. The Arkansas Children's Hospital realized that their staff was not practicing hand hygiene to an acceptable level last 2012. The baseline hand hygiene compliance was 75%. The final project goal was to improve hand hygiene compliance to equal or more than 95% by 2014 and to find strategies that would best achieve this goal. Project ownership was given to the hospital infection prevention team, in which in turn formed the hand hygiene improvement team. Initial intervention followed WHO's advice, which included education on hand hygiene, leadership commitment, reminder signs, hygiene supplies being readily available, and sharing data with staff. However, these interventions improved the compliance by 7% only, raising the data from 75 to 82%. After the WHO action template, Speaking Up for Safety program was implemented across the hospital. The program became the ultimate error prevention tool as it trained staff on how to speak to those who weren't complying with hand hygiene protocols. It also set up a chain of command for reporting if resistance was found. The staff were given a script for how to discuss hand hygiene with their colleagues. It has an acronym ARC, or Ask, Request, and Give Concern. What's more, if a staff member was concerned that someone was still refusing to comply, the middle manager or the local nursing director would speak to them personally. Reporting of events were documented and tracked on cards, which were also used as raffle tickets. In short, they were incentivizing speaking up on hand hygiene-related issues. Incentivizing speaking up and setting up consequences for non-compliant personnel cultivated a culture within the hospital and increased hand hygiene to a sustained 95%. If not speaking up can cause patients harm, then why do people stay silent? Whether an individual speaks up or not is influenced by a number of factors. It could be personal, such as age or personality, organization, which includes position in the hierarchy, contextual, such as organization's policies and culture, or sociocultural. A specific culture can shape the organizational norms within the hospital, which in turn can influence the employee's willingness to voice an opinion. Perceived effectiveness of speaking up. A study conducted with the nurses several years ago found that more than half had been in situations where they felt it was unsafe to speak up. Although nurses in the study were more likely to take their safety concerns to their managers than to speak directly to the practitioner who is in question, fewer than half of these managers followed through and spoke about the reported safety issue. Thus, taking safety concerns to a manager may not produce reliable results. Perceived safety of speaking up. Psychological safety is the belief that you won't be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes. It should embrace a culture of respectful debate, dismantle perceptions of hierarchy, encourage personal storytelling, and model openness for feedback on employees' views. Motivation to speak up. Employees are motivated to speak up also when they have a high index of suspicion, a high index of patient harm seen, they are empowered, they are intolerant to risk, and the workforce around them encourage and model speaking behavior. A high index of suspicion means that a provider has sufficient or significant cause to believe that a patient is or may soon be actually ill or injured. Individual factors. An employee who is confident, knowledgeable, has a good understanding of best practices, has prior favorable experiences of speaking up, will have the tendency to be more vocal about a safety issue on hand. Moreover, an employee who is in constant fear of damaging collegial relationship as a result of speaking up will have reduced speaking up behavior. Contextual factors. When an employee is given adequate time to consider potential error, if the reporting process is not cumbersome and complicated, there is a reference for interdisciplinary policies for speaking up, then that employee is most likely to be heard reporting a safety-related issue. Tools and training. Organizations who are giving opportunities for its personnel to learn about the principles of patient safety, such as attendance to team steps updates, has a standard structured speaking rubric such as SBAR in the workplace, has an established and audited opportunities for speaking up such as surgical timeouts and I pass the baton during handovers, communication regarding patient safety will be greatly enhanced. Dr. Timothy Lesar of Albany Medical Center in New York listed the phrases he called the magic words, which have been repeatedly offered in explanation to voice concern and erroneously accepted as evidence. These words still ring today along with many others. Such phrases should be viewed as red flags and should be given with adequate answer according to the situation presented. To give us a picture of a hospital in the local setting regarding its speaking up for patient safety initiatives, allow me to take the Philippine Heart Center, a 531-bed government-owned and controlled institution in Quezon City, specializing in cardiovascular diseases of both adult and pediatric, as an example. To encourage the internal and external stakeholders to speak up regarding patient safety, the hospital has created the online voluntary incident reporting. This is a hospital-wide endeavor spearheaded by the Safe Hospital Culture Team along with the Hospital Safety and Risk Management Committee. The generation of voices in relation to patient safety issues is made possible through the QR codes in posters that are placed strategically in the hospital. Entries for this will be received by the planning officer for safety and processed according to the nature of the reports. It has an inclusion criteria regarding what type of reports are valid. Those who can report, all PHC staff, patients, both inpatient and outpatient, as well as visitors. Only documented, reported, and witnessed events shall be processed. For its exclusion criteria, Requests for assistance, for example, financial, ambulance conduction, scheduling, alleged illegal detention, and medical requests for diagnostic procedures are not entertained but forwarded to the concerned offices. Employee queries, issues, and concerns such as delayed bonuses, recruitment, late processing of retirement funds, as well as concerns and issues beyond the scope of PHC and the Civil Service Commissions are excluded. The guidelines for its use are posted in the hospital intranet. Pathway for the processing is around 3 days with variances noted at 24-hour intervals. Before the advent of QR codes, the nurses in the hospital floors, ICUs, and special areas have been using the online voluntary incident reporting in their desktops for nearly a decade already. This allows them to document right away any form of incident reporting, be it related to patient safety, workplace aggression, or facility safety. To safeguard the psychological safety of the employee regarding their speaking up about unprofessional and disruptive behavior among other healthcare workers, the Task Force Workplace Harmony Committee was created by the Office of the Executive Director to look upon reports of that nature. This is parallel to the program Safe at Hopkins, as previously discussed in the case study. For our critical language, the Philippine Heart Center have embraced the acronym PEN, which stands for Please End Now. This is usually used when an employee needs to stop a questionable action of another employee without embarrassing him, especially when there is an audience around. This is parallel to the Arkansas Children's Hospital ARC Ask Request Concern and the COS, an acronym for I'm concerned and comfortable, please stop. To address the multiple issues arising from everyday operations, these are the patient safety-related committees that take action in order to resolve and prevent any form of problems, as well as to act as avenues for the employees to speak up. Before I end this lecture, Sir Jackie Stewart, a renowned British Formula One racing driver from Scotland, quoted, "It takes leadership to improve safety." Sir Jackie Stewart was instrumental in improving the safety of motor car racing, campaigning for better medical facilities in crash sites, and track improvements at motor racing circuits. Thank you for listening. Magsalita para sa kaligtasan ng pasyente, and to honor my Aklanon roots, maghambal para sa kamangayran it pasyente. Good morning and have a good day.
Thank you very much, Ma'am Cherise, for an excellent talk. Speaking up is really something that we should do, and we Filipinos should actually work on, kasi we're used to speaking up, but mainly to help others, like giving directions, but not to correct people and comment on their disruptive behavior. But of course, as you said, ma'am, for patient safety, to prevent medical errors, to promote better outcomes like decreasing hospital-acquired infections, we have to speak up. And of course, you also emphasize the need to report incidents undermining patient safety. So all members of the team taking care of the patients should truly have the courage to speak up. Speak up kahit nakapikit. Pwedeng sabihin, Doc, maghugas muna po kayo ng kamay. Please po, with a lalagyan ng Korean heart. Sige na po, hugas muna ng kamay. So anyway, thanks, Ma'am Cherise. And I think many participants will have some questions later on, but again, reminding everyone so that you will not forget your questions. Don't be shy. Speak up. Please type in your questions in the Q&A tab or maybe in the chat box as well. So now we are on to our last, but certainly not the least speaker. Our last speaker is Dr. Vic Malabonga, who is an expert in pulmonary critical care and sleep medicine. He finished his internal medicine at Wayne State University School of Medicine and pulmonary medicine and critical care at SUNY Downstate School of Medicine. He is currently the Chief Executive Officer of SR Consulting, which takes care of healthcare systems redesign for quality and performance improvement. He is the former Chief of Staff at the Central Alabama Veterans Healthcare System. Dr. Malabonga has conducted patient safety lectures at the Philippine General Hospital, and this time he will talk about interprofessional teams in promoting psychological safety in the health workplace. So please let us all welcome Dr. Vic Malabonga.
Thank you for the kind introduction. Magandang umaga sa inyong lahat. The title of my talk today is Interprofessional Teams in Promoting Psychological Safety in the Health Workplace.
Dr.
The
Malabonga.
Hello?
Sorry, I need to, yes, this is Dr. Cson, your session chair. Your video seems to be inverted. So it looks like you're hanging upside down. So I'm not sure how to.
I actually am.
Yeah, you are. I hope you're not dizzy.
No, I'm getting a headache actually
joking.
from hanging
So
upside
maybe,
down.
Yeah. I'm not so
trying
sure
to figure out how
maybe
do you.
our tech person here can help Dr. Malabonga correct the camera position. Is it what are you using, sir?
Desktop.
Oh, desktop.
Yeah, but I've used this before, and in the dry run, it was okay. My image was upright. I don't know what happened.
Okay, they said that it must be in the setting of your camera. Okay, someone's helping you. Thank you. So where are you now, sir?
Yes.
You're in the US, right? What time is it there?
It's it is 8:30.
Okay. In the evening?
Yeah, in the evening.
Yeah, okay. So it's currently 9:30.
But I'm sure it has nothing to do with me hanging upside down. I don't know. I really don't know what happened. I've used Zoom for.
Would it be better if I don't know, if you exit first and then go back again? Maybe that will help.
Yeah, let me try.
We'll wait for you.
Let's do. Yeah, this is going to be fun. Let me come out first. Oh, yeah, there you go. But what do you want to do? Just stop share and then share again.
Yeah, I think we can try that first.
Where's the window? Now I can't see.
I'll consult some of our team as well.
Oh, how about that one right there? Yeah. Yeah. Okay, there we go. All right.
Okay, that's perfect.
Am I good now?
Yes. Thank you, sir. Go ahead.
All right.
So again,
Yeah.
round of applause for Dr. Vic Malabonga.
Yay! Thank
Yay.
you. Yeah, I brought my son over from Los Angeles just to help me with this one. I'm just kidding.
Okay, thank you, son.
Anyway, so the title of my talk today is Interprofessional Teams in Promoting Psychological Safety in the Health Workplace. And the subject of interprofessional teams with psychological safety is a complex one. Therefore, I would like to frame the discussion around one, the mechanics of interprofessional team functioning in the healthcare setting. Two, behavioral characteristics of effective interprofessional teams. Three, communication as the linchpin of effective team functioning. And four, the role of team interventions to enhance team effectiveness. There are two take-home concepts I would like to highlight. First, the definition of psychological safety that I would like to use is a mental state where members can openly disagree, respect each other's input, and walk away without taking things personally. That is the goal. That is the state that we eventually want to be at. The second take-home concept is that it is not the team itself that promotes psychological safety, but the environment and context under which it works in. Let me repeat that. It is not the team itself that promotes psychological safety, but the environment and context under which that team is working in. Subsequent slides will address this in greater detail, but the reason that this concept is relevant is because a socio-technical environment defines the milieu in which these teams operate. An interprofessional team is immersed in a dynamic and complex setting with periods of workload unpredictability. Moreover, it requires the interaction of various disciplines, and these disciplines are often hierarchically organized. They bring with them differences in training and varied approaches to communication, as well as individual member personalities and values. Because these teams often work in high-risk settings with temporally unstable team compositions, the management of complex work often involves the delegation of work components. In this situation, there's a tendency to emphasize division of labor. When the focus becomes the division of task work rather than the synergy of the whole, then there is a potential to overlook coordination and integration. If this happens, then kanya-kanya na sila, which leads to a mess of things. So what are the factors at play here? In forming an interprofessional team, we typically pick the required disciplines for the job. However, it's not enough that we put all these components in a room and just tell them to do great things, right? We also need to define the relationship of components, which can be cyclical, spoke and wheel, hierarchical, or something else. We also have to establish the direction of flow of action and or information. Is it sequential, alternating, parallel, simultaneous, or somewhere in between? Notice that in the previous relationship slide and the current direction of flow slide, there are lines that connect the various components. These lines are what make the team interprofessional. Without the lines, all you have is a collection of disciplines, each working on their own. The lines that make the team whole are the lines of communication. For the components to work together well, it is essential that they talk to each other. Because an interprofessional team requires relationship and flow to function, it is apparent that knowledge and skills alone are not the only determinants of teamwork effectiveness. The relationship plus flow factors in this equation indicate that the foundations of teamwork are effective communication and coordination. The main point here is that without communication, there's no coordination. Without coordination, there's no effective work. Now, when we look into the individual member factors at play in the inner workings of an interprofessional team, two general categories can be found. One, surface level and deep level constructs, and two, technical and non-technical competencies. Surface level variables are such things as age, the type of discipline, the method of training they undergo. Deep level variables, on the other hand, are psychological attributes like personality and attitudes that are discoverable only after interacting with someone. Technical competencies are self-explanatory. The non-technical competencies have been defined as a set of social and cognitive skills that support efficient and safe care. Examples are the ability to communicate, work in a team, analytical skills, and personal behavior. These social, cognitive, and technical abilities are what comprise that socio-technical environment I referred to in the previous slide. When components, relationship, and flow come together through effective lines of communication, certain behaviors become manifest in highly effective teams. Haynes and colleagues in 2011 reported that these teams engage in adaptive coordination, critical task execution, intentional listening, and speaking up deliberately. Salas and colleagues in 2009 noted that these teams exhibit adaptability, implicit and explicit coordination, shared leadership, and conflict resolution. Note that coordination, listening, speaking up, adaptability, shared leadership, and conflict resolution all fall under the categories of deep-level variables and non-technical competencies. At this point, it is clear that interprofessional effectiveness is heavily influenced by open communication lines, the psychological attributes of team members, as well as their social and cognitive skills. The goal then for effective team functioning is to establish an environment where team members form cohesive social units, interdependently function, and adapt over time to achieve shared goals and manage complex work. Achieving this requires extensive communication between team members. It has been found that teams that involve interdependent disciplines over prolonged periods of time, as occurs in the ICU, acute care ward, rehab ward, and long-term care, tend to communicate in informal, non-standard, and fragmented fashion. Informal, non-standard, and fragmented communication. What does this mean? It means these teams are a breeding ground for communication failures. And how important is open communication to effective team function? Rabol and colleagues in 2011 reported that communication failures were found to be involved with 60 to 70% of serious patient incidents in their institution. A Joint Commission report in 2014 noted that at least 60% of sentinel events were associated with communication failure. Moreover, an Australian study in 1995 found that preventable deaths were twice as likely to be caused by communication failure as error of technical competence. Fortunately, there are interventions available to improve team effectiveness. These are team training, communication tools, simulation, and coaching. Formal team training programs like crew resource management and team steps focus on the development of non-technical competencies like communication, situational awareness, leadership, and situation monitoring. The aim of communication tools like checklists, handoff protocols, goal sheets, case analyses, team briefs, and debriefings is to formalize the communication pathway in an explicit, structured format. This facilitates speaking up and more open communications. Simulation and coaching are also effective training approaches. In a meta-analysis of team intervention studies from 2000 to 2012, Weaver and colleagues found that simulation and classroom-based learning consistently improved team processes in communication, coordination, and cooperation. There's a caveat here, however. No matter how well conducted team interventions are, their impact on actual behavior and outcomes in the long run can only go as far as the pre-existing organizational safety culture will allow. This is because the safety culture is heavily influenced by leadership. The impact of organizational leadership on safety culture is profound because leaders influence the collective perception of values and priorities. Whatever is important to the boss through word, policy, or action will be noticed and prioritized by lower members of the group. It's a natural phenomenon of group psychology. This determines whether robust safety and just culture will pervade the organization. And it is this organizational culture which provides the condition that promotes effective teamwork. Long-term improvement after team training requires that organizational policies, reward structures, and culture come together to align with and support the expected values and behavior. This is why, or this is one reason why, organizations high in safety culture see large benefits from team training, while those with low safety culture see little or no benefit at all. To drive the point, the first step to psychological safety is that organizational and team leaders establish a safe and just culture. Then, team interventions and tools are applied. As these take root in the affected interprofessional teams, that is when improved team communication and team dynamics are observed due to enhanced psychological safety. In summary, communication and coordination are the foundations of teamwork. Deep-level variables and non-technical competencies are the dominant team dynamics for effective communication and teamwork. Simulation with classroom-based learning consistently improved team processes related to communication, coordination, and cooperation. Lastly, low or absent just culture inhibits team psychological safety. This ends my presentation. Salamat sa inyong lahat.
Thank you very much, Dr. Vic Malabonga. That's quite enlightening, highlighting, of course, the importance of teamwork, coordination, and cooperation, and more than that, emphasizing that the environment somehow sets the safety and the just culture, and that leadership really has an impact on achieving a safety culture wherever you are. So I think it's now time for our Q&A, and may I ask all our panelists to please turn on their cameras. Thank you very much again to our speakers, Dr. Lynn Panganiban, Ma'am Charis Magallanes, and Dr. Vic Malabonga. Kindly turn on your cameras po. Hi, Ma'am Lynn. I think we have questions here. Okay, so let me start. Dr. Velasco. Okay. Okay, there are some questions here, but it's not Okay, for Dr. Panganiban, it says here, I want to know more about the I'm safe checklist. Thank you so much. Maybe you can tell maybe the participants where they can get their checklist and how this can be used in order to build a culture of safety in their institutions, Ma'am Lynn. Thank you.
Okay, thank you, Connie. Good morning to everyone. I'm safe checklist is just one of the checklists that we can use, and this is for situation monitoring. So I'm safe was developed by AHRQ as part of the team steps training. It stands for I is illness. This is something that before you get to work, this is like a list that you can like self monitor yourself if you're ready to go to work. So I will stand for illness. M is medications. If you're on maintenance medication, are there adverse effects that you are experiencing at the moment, and that might hamper your work? I'm safe. S is stress. Is there anything? It might be work related, personal, home, family related, stress in your life that might get in the way again of performing your work. And A is addiction. More and more, this has become like a problem even in our hospital. I don't know, in PGH, we do have that problem many years ago, and we need to address that. Are you now into some dependence, not just maybe illicit drug use, but some of them dependence because of the maintenance medications that you're in? So the F is fatigue. Okay, so did I go for like a 36-hour duty, the previous duty that now I was asked by whoever is my superior, whether you're a nurse, a pharmacist, or a doctor, that you have to go to work. So are you ready, or are you just over fatigued at this time? And funny, the last is eating and elimination. Do you in your workplace or in your time schedule will allow you not to go through your break to take in some meals or food, and even to do your usual health break? And so this is just a checklist, and you can add on to whatever there is in your hospital setting, not that you can like a guideline for you before you get to work. So part of a situation monitoring tool. I
And
hope
to
I
check,
answered the question. Thank you.
yes, ma'am, I suppose so. So this is for the healthcare workers. And what if they find themselves not safe? Can they report this? I am not safe. And maybe help can be given to the healthcare workers. Thank you, Ma'am Lynn, for that. For Ma'am Cherise Magallanes, as was said earlier, maybe a barrier in our Philippine culture is that we're not used to speaking up. Can you relay your experience in a heart center on how, for example, kasi minsan we somehow uphold hierarchy, or there's this culture in the hospital, hierarchical, the doctor is almost always right, and medyo we are not really keen telling them that they're wrong. So how did you build or promote speaking up when, for example, in the operating room or in the ICU, and so that this environment of safety culture to uphold patient safety will be there?
Okay, good morning. Thank you for the question. In the Philippine Heart Center, totoo yung sinabi niyo, Doktora, na especially in the Southeast Asian countries, the culture of honoring more the senior leadership, whatever their decisions are. So parang especially in Korea, in Japan, hindi na kina-question ng mga subordinates. But in the Philippine Heart Center, we have broken that barrier, especially in the floors, even the ICUs in the operating room, by implementing the online voluntary incident reporting. So with that, with the online voluntary incident reporting, the staff nurses are protected from harassed by whoever they are complaining about, by putting their complaints directly into our desktops using only their employee number. And the movement, the flow of this online, or we call that OVR, it has an escalation process that the moment the staff writes his complaint, it immediately alerts his next immediate supervisor that there is an incident report for him to review. And then when the incident report was investigated by the head nurse or the unit manager, it goes also directly to the division chief, and then subsequently to the division, for the department manager, and then to the nursing director. So with this, the staff is safe, psychologically safe, that he will not be harassed along the way while his complaint is being investigated. And in the operating room, actually the task force workplace harmony ay galing sa operating room. Kasi alam naman natin, the operating room is a highly stressful and challenging situation. And there was, I think, an incident between a surgeon and operating room nurse na ang reklamo ay nakaabot sa aming hospital director. And with that, the hospital director created the committee, which is chaired by the surgeon mismo and vice chaired by the anesthesiologist, and the remaining members are of a multidisciplinary nature, like the alliance officer, the nursing manager, the operating room head nurse, as well as senior nurses from the ICUs. So sa arrangement po na ito, and also with the coming QR code namin, speaking up for patient safety, mas lalo pong na-expand yung OVIR na ito into our external stakeholders such as the doctors and the patients and outpatients. So hindi lang po yung problema sa clinical situation, kundi yung facility safety and the environment, other complaints such as harassment, theft, and security. So yun po yung naging malaking impact sa amin ng speaking up for patient safety initiatives.
Thank you, Ma'am Chavis. And
Yes,
Dr.
comment?
Bonga. Yeah, I was actually about to ask you if if speaking up is verbally speaking. I mean, using your words by mouth, or is incident reporting also a form of speaking up? Can you comment on what Ms. Charis just said?
Yeah. Well, I wanted to comment with regards to the question, because when you look at the actual clinical setting, speaking up is face-to-face. In the rapid response team, the code team, the operating team, the ICU team, these are all active, ongoing, face-to-face situations. And so there are a few strategies that can be applied. First, organizationally, it should be pushed from above, from the director office level, to formalize the communication pathway. What I mean by that is to have scripts, to script the communication. So you have a handoff protocol for transition of care from
standardized
shift to shift, or from ward to ward, or from ICU to the regular ward. And you can use SBAR, situation, background assessment, recommendation. And then you can have checklists and goal sheets for when the team first meets in the morning, so they can be clear on what's supposed to happen, who has to do what are the goals, and what are the difficulties we may encounter. And then this is during team briefings. And then you can also have debriefings, but all of these have to be scripted, because if it's a free for all, then hierarchy will take over, especially if you have a domineering position who is in the, he or she doesn't have to be the leader, the team leader. He or she just has to be a domineering personality. So that's two. The The third is trying to flatten the hierarchy within the teams as best as you can. And again, how you flatten the hierarchy is um, by proceduralizing the communication, making it, this is how we're going to talk about this. It's going to be scripted, and you all are going to follow the plan, at least for the communication pathway. I'm missing out on the last one. I had it and then it disappeared. Oh yes, and then you can use what we call graded assertiveness. Examples have been mentioned before. You can have the mnemonic is pace, probe, alert, challenge, and emergency or escalate. Another one is cuss. This is referred to, I think, by this Sharice, yeah.
Yeah.
And cuss is concerned, uncomfortable, unsafe, and then stop. And then there's the more diplomatic one, which is the 5-step advocacy. So I'll give an example for the same example for all these three, right? So 5-step advocacy is get attention, state your concern, get attention, state your concern, state the problem, offer a solution, and then try to get agreement. So if I'm the nurse, I get attention. Excuse me, doctor, state a concern. I'm not quite sure we're getting an end-tidal CO2 training. This is after intubation, okay, in the ICU. And then the problem is, well, is it possible the intubation was not successful, which is why we don't have an end-tidal CO2 tracing? Offer a solution. Can we consider re-intubating the patient and bag him in the process so we can get a correct tube placement? And then the fifth one is, do you think that's a reasonable and safe thing to do? So that's the 5-step advocacy. If I were to use the PACE, so probe, I would say, did anybody notice if we have an end-tidal CO2 tracing, right? And then for the alarm, I would say, oh, I don't think there's an end-tidal CO2 tracing. The challenge is, there really is no end-tidal CO2 tracing. I don't think this guy is properly intubated. And then the emergency is, we have to take the tube out to get a proper end-tidal CO2 tracing. And then the CUS is just, a modification of the PACE. It's the same thing. Anyway, so those things, organizationally, you institute a communication policy, and then you proceduralize using the communication tools, you flatten the hierarchy, and then teach the staff and encourage them to use those graded assertions that I just mentioned.
Okay, that's very helpful, Dr. Malabonga. And I think in Heart Center, correct me if I'm wrong, Ma'am Cherise, I think you're doing that. The nurses are very empowered in the Philippine Heart Center in the ICU settings. So although there's incident reporting online, I know you also do this. Am I correct in Heart Center? How do you do it? But it's good to know na having a script will also make it easier for people to speak up.
Yes, correct, Doctora. We do have standardized scripts for reporting, like as Dr. Malabonga had said. For endorsement, we use I pass the baton, and for referral, we have ISBARCs. Actually, is a modification of ISBAR. We have added C and S at the end of the ISBAR, which means contingency and synthesis. So we usually use that standard mode of communication during referral to doctors. And also, personally, the nurses, especially with the ICUs, I think they're already empowered, and also the fellows being oriented right at the start that the hospital culture has a just culture, has a blameless culture, but it doesn't mean blameless. We do not value accountability. Hindi ibig sabihin na pag nagkamali ka is and it's blameless, hindi ka namin tatanungin. So we balance just culture with accountability. So and also not even just our fellows, but our consultants, both young and old, are also well informed about this culture of ours, and probably majority of the Philippine hospitals nowadays.
So because we're talking about culture, there are some questions here in the chat box addressed to me personally, and maybe any one of you can answer. In this generation where speaking up has been tagged as bashers or reclamador, how can we break these labels? And maybe connected to that is a question on what is your take on the fear of staff and personnel in reporting of incidents due to still fear to be of blame, a culture of blame or fear, or the culture of being punished or sanctioned or reprimanded. So
may I answer that, Doctora?
Okay, go
just
ahead.
like with the case study in John Hopkins, the evaluators from Cambridge University showed the senior leadership of the John Hopkins hospitals that what they found out during the interview is that the staff responded that they are afraid to speak up because they might be termed as a bad team player, or they might be disappointed because their complaints might just go to waste, and that the person they are trying to report will not be given consequences. So the Cambridge University evaluators showed this results to the senior leadership, and they have revised the reporting and the translating of all these studies. And then the John Hopkins Medical leadership realized what they need to do in order to give a speaking behavior a boost to their staff. So ito po yung kailangan maintindihan ng sa taas. Kasi like Sir Stewart, safety begins with leadership. Kasi kahit anong magandang protocol sa ilalim, anong magandang leaders ng medication safety, fall prevention safety, blood management safety, basta hindi yon sinusuportahan ng leadership, hindi po yun magiging successful.
Right.
Thank you.
Yeah. So it's yeah. Okay, Ma'am Lynn, go ahead, please.
I just have 2 points on that. Yes, I think it's very much emphasized about active leadership. Na nakita naman natin ang active leadership is really one of the, I think, fundamental enabling factor para makadevelop tayo ng value system natin, no? Not just our own individual, but as a team and as an organization pagdating sa culture. Pero siguro it's more of sa atin din initiative on our end to be able to start it. Kasi parati, hindi man parati tayo na kasi si leader natin, kasi si ganyan natin. But this is also something that we can work within ourselves and to enrich kung ano yung merong kultura meron tayo. Alam mo yung ating pag-aaral sa mga Filipino healthcare workers, magaling ang team work natin sa isa't isa. And I think we can strengthen that and we can build eventually a strong leadership. Pero ang maganda rin kasi sa reporting, kailangan there has to be some element of privacy and confidentiality. Kasi ang takot kung minsan talaga natin is that when we report, buong bayan alam na, buong hospital alam na, when everything has not even been looked into yet, no? Because naandun na yung takot kasi yun nga, they are going to issue out as reporting. And this is true by my experience. When we do have drug problems in our workforce, no, ang mga substance abusers, and we cannot negate that. That's a reality that's happening right now sa ating setting. Pero kung wala tayong safeguard measures to ensure the employee that we are there helping them out, wala rin mangyayari. So I think the safeguard measures and as far as privacy, confidentiality is there. And maybe the third point is that systems in place. Kasi kung wala tayong system in place, kung paano tayo mag-report, no? Then wala na. Everything ilalagay na lang sa Facebook, kung saan-saan na lang na of course it will jeopardize.
Social
Then,
media, right?
yeah, media, etc. But if there's a system in place, I know in PGH we do have that blinking light in our radish. Do you have safety ba? Do you have a safety issue concern? As of now, you just clicked it. You can type your concern, and it will a team that will keep your report in confidence, in of course respect privacy. Unless it becomes a big issue that it will involve so many people, then it's something that we need to act on right away and involve the people who are into this concern.
Right.
Just
Meron
my thought.
tayong kasabihan dyan, Ma'am Lynn, ano yun, may pakpak ang balita, may tenga ang lupa. Kaya people are afraid to speak up.
Yes.
But maybe my question is for Dr. Vic Malabonga. No? We are lucky, blessed in PGH to have such a leadership that supports patient safety. But there's a question here that what if the leadership is not supportive? How can we advocate patient safety? How can we deal with the frustration short of ousting the leader? Anyway, so what are the steps that the participants may take here, if the leadership is not here, on trying to advocate for patient safety? Because you said leadership is important in establishing really the culture of safety or the safety environment. Dr. Malabonga.
Well, unfortunately, I'm going to be the bearer of bad news. If top leadership will not support the patient safety initiative, it will be extremely difficult for a hospital-wide patient safety program to move forward. However, you see, when you look at a hospital culture, it is not homogeneous. A hospital culture is a quilt work of mini cultures. So the culture in Ward A, the safety culture, is going to be different than Ward B, depending on the nature of leadership from the nurse, manager, or whatever you call it, a head nurse or whatever, and the department head over the physicians in that particular area.
Right.
The safety culture in the ICU will be different from the safety culture in the operating room. Again, depending on the leadership of the nurse manager, head of surgery, head of the ICU. So initiatives to promote a safe and just culture within a particular unit are very, very possible.
Okay.
But that doesn't cover the rest of the hospital. For example, when we look at medication safety, that has to be hospital-wide. It can't be just in one unit.
Yeah.
Because the steps, the measures you implement to improve medication safety involve the interaction of different departments: procurement, logistics, transportation, pharmacy, nursing, medicine, security for narcotics, and all that stuff. So there are certain things that can be done at the unit, meaning at the ward level, but there are certain things that have to be addressed at the top. And if when you look at the adverse events, that what contributes the most to adverse events in a medical center, it's transitions of care and transitions between units. Those are the two most critical areas where patients fall off as far as adverse events are concerned. And that involves not just one unit, but multiple units. So hospital involvement is really, really critical.
Okay, yeah, that's good. Thank you, Dr. Malabonga. There's hope by starting small in your unit.
Yeah.
And maybe if success is shown in your unit, then this can actually maybe encourage the leadership to for them to buy in these specific strategies in your own unit. So thank you very much. There are a lot of questions still, but there's no more time. But I think that everybody will agree that this has been quite a fruitful discussion, and they're ready and excited to bring all their learnings from this session to their own areas po. So thank you very much again to our speakers, Dr. Lynn Panganiban, Ms. Maria Cherise Magallanes, and Dr. Malabonga. Thank you everyone for attending this session. We have learned that safety culture is necessary to promote patient safety and to achieve good healthcare outcomes, but it's hard work. It's built up by setting the right environment for which leadership has great impact, but we all can start small by working towards good team dynamics where open communication and coordination are valued and prioritized. And all of these strategies actually towards reaching these were discussed and addressed during the Q&A by our excellent speakers. So thank you everyone, and thank you again to our speakers.
Thank you.
Thank you. Bye-bye.
Bye.
Thank you.
You may visit our website for session recordings, oral, and poster presentations. Please also access our Facebook page and vote for your favorite advocacy video. And lastly, as stewards of patient safety, we are inviting you to sign our pledge of commitment to patient and healthcare worker safety. Please access the link found on your screen.
Thank you very much for attending the sessions of the clinical track. We shall have a 5-minute break to wait for the participants to enter this Zoom meeting room for the plenary session.
The University of the Philippines, the only Philippine university to be named in the top 100 universities in Asia. This state-run institution is a paragon of education steeped in history and culture. The University of the Philippines system is composed of 8 universities around the country. The oldest of which is the University of the Philippines, Manila, the birthplace of the UP system in 1908 in Padre Faura, Ermita. Its oldest unit, the Philippine Medical School, later renamed to UP College of Medicine, opened in 1905, followed by the Philippine General Hospital in 1907. From the College of Medicine evolved other colleges and units that diversified the university's course offerings. In 1948, UP was transferred to Diliman, Quezon City, leaving behind some health colleges and the College of Arts and Sciences. In 1976, the School of Health Sciences was created in Leyte, to offer a community-based, ladderized health education that aimed to help increase the availability of trained health workers in the province. 2 satellite campuses of the school were strategically set up in 2 other remote and underserved provinces, namely Baler Aurora and Coronadal, South Cotabato. The creation of the Health Sciences Center in 1977 brought together all the health units under one roof. The center was renamed to UP Manila in 1983. Today, UP Manila is the recognized pioneer and leader in health education, research, and public service in the Philippines. Among its pioneering programs are university-wide BS Nursing, Master of Arts in Nursing, PhD Nursing, Master of Health Professions Education, Integrated Arts and Medicine, degree programs in Public Health, MD PhD, MA Health Policy Studies, MS Health Informatics, MS Genetic Counseling, PhD in the Health Sciences by Research, and the only ladderized midwifery, nursing, and medicine degree program of the School of Health Sciences. UP Manila's credentials have led to its being the partner of choice of the World Health Organization, Department of Health, Department of Science and Technology, Commission on Higher Education, and other local and international groups to achieve health reforms. UP Manila is the only campus in the UP system that offers education, research, and training in a wide array of health disciplines and professions. The university offers courses in medicine, nursing, pharmacy, dentistry, allied health sciences, public health, health professions education, community health, and the arts, natural, and social sciences. The competency-based curriculum makes it stand out among the other schools. Since 2014, in compliance with the Philippine Qualifications Framework, the colleges are now transitioning to outcome-based education, or OBE. It enables the well-rounded development of students and unlocks their full potential as both health professionals and dedicated Filipinos. UP Manila educates the brightest students in the health professions and allied social science disciplines. Its students consistently top licensure examinations and assume positions of leadership and influence in government, the private sector, academe, non-government sector, and the community, giving them opportunities to shape national policies and programs on health. UP Manila is a pillar in the field of health research. UP Manila ensures that its faculty, staff, and students engage in research as a tool for health reforms to enhance education and complement its public service role. With the help of the National Institutes of Health, the center of and coordinating body for all researches in the university, UP Manila's researches have served as basis for national policy formulation and program planning. UP Manila's firsts in health research and policy include Republic Act 9288, the Newborn Screening Act of 2004, RA 9709, Universal Newborn Hearing Screening and Intervention Act of 2009, RA 10747, Rare Disease Act of the Philippines in 2016. Other advocacies include the studies on liver diseases that led to the mandatory vaccination of newborns against hepatitis B, commercialization of Lagunti and Sambong as proven effective medications for cough and colds based on the results of the National Integrated Research Program on Medicinal Plants, the Ventilator Project, and the Vision Screening Project for newborns and school children, all of these for healthcare improvement. Strengthening this role is its public service function rendered through the Philippine General Hospital, its community and volunteer programs, and scholarly and technical assistance to the government, private sector, and civil society. As the Philippines' biggest government and tertiary hospital, the PGH sees more than 500,000 patients a year from all over the country. It trains thousands of health students and health professionals from within and outside the university. Among its innovative programs are on child protection and poison control and management. Volunteerism is strong at UP Manila. From the very beginning, students are ingrained with their role as public servants. Through the ugnayan ng pahinuod, faculty, students, staff, and alumni volunteers provide health and socio-cultural services that benefit depressed communities and indigent Filipinos. And to further reach out to the larger society, UP Manila offers the Community Health and Development Program and other community-oriented programs. This combination of excellent education, relevant research, and public service has produced thousands of exemplary doctors, nurses, dentists, pharmacists, public health experts, rehabilitation workers, paramedical workers, and more. With more than 100 years of excellent leadership in health, UP Manila is keeping itself nationally relevant and globally competitive by being at the forefront of Philippine health. The challenge may change, but UP Manila's response will be certain, excellent, relevant, and transformative.
The COVID-19 pandemic has changed our lives. UP Manila, as the Health and Sciences Center, is expected to carry a significant burden in terms of patient care and, more importantly, take the lead in looking for solutions. UP Manila as an institution has responded in many ways. The PGH, or the Philippine General Hospital, serves as one of the COVID-19 referral centers of DOH, committing its health workforce to serve. The UP-PGH COVID-19 Bayanihan na Operations Center, manned by volunteer faculty, students, and staff as they respond to patients and donation queries.
Welcome back to our plenary session. We hope you had a great time from the lectures and our simultaneous sessions and the 3 tracks prepared for you. So just a few reminders before we start our closing plenary.
Welcome to the 3rd Patient Safety Congress, organized by the University of the Philippines, Manila. Please be reminded of the following rules during the Zoom webinar session. This event is being recorded. You may type your questions in the Q&A box at any time during the lecture. The meeting facilitator will take note of them for discussion during the Q&A session. Kindly revise your name to include your institution. An example for renaming is found here in the slides. The Congress is divided into three tracks, namely the Executive or Leadership track, the Clinical track, and the Innovations or Education track. The third Patient Safety Congress has been applied for PRC CPD units for the following professions: medicine, nursing, pharmacy, dentistry, midwifery, and physical therapy. You may visit our website for session recordings, oral, and poster presentations. Please also access our Facebook page and vote for your favorite advocacy video. And lastly, as stewards of patient safety, we are inviting you to sign our pledge of commitment to patient and healthcare worker safety. Please access the link found on your screen. Welcome.
Good morning, everyone. I am excited to welcome you to the closing plenary of the Third National Patient Safety Congress. I am Diana Tamundong La Chica of the UP Program for Healthcare Quality and Patient Safety, your session chair for the closing plenary. In this plenary, which we have entitled Forging Partnerships with Patients and Families in Improving Safety in Health Facilities, we will highlight the critical need to create and sustain an alliance with patients and families to achieve patient and workforce safety. It aims to present perspectives from different stakeholders, namely regulatory agencies, the academic and scientific community, and the patients themselves in building a holistic action plan and commitment for patient and family engagement towards safer healthcare. Let's get to it. We will start the plenary by hearing from our first speaker, who will talk to us about enabling mechanisms for effective patient health worker partnership towards patient safety. He took his Bachelor of Science in Health Sciences in the Ateneo de Manila University and Doctor of Medicine and Masters in Business Administration in the Ateneo School of Medicine and Public Health. He also served the Northern Samar Provincial Hospital in several key positions. He is currently the chair of the DOH Technical Working Group for the Patient Safety Program in Health Facilities and the OIC Division Chief of the Policy Planning and Program Development Division of the DOH Health Facility Development Bureau. Everyone, please welcome Dr. Terence John M. Antonio.
A pleasant day to all. I'm Dr. Terence Antonio, the chairperson of the Technical Working Group for the Patient Safety Program and the Division Chief of the Policy Planning and Program Development Division of the Health Facility Development Bureau. Today, I was tasked to present the enabling mechanisms for effective patient health workers partnership towards patient safety under the theme of the closing plenary entitled Forging Partnership with Patients and Families in Improving Safety in Health Facilities. The outline for my discussion includes providing a brief overview of the Health Facility Development Bureau, followed by the available enabling mechanisms for effective patient health worker partnership, and lastly, the direction of the National Patient Safety Program to support the program implementation. The Health Facility Development Bureau, or HFDB, is under the Department of Health, Health Facilities and Infrastructure Development Team, or HFIDT, which is led by the Undersecretary Lilibet C. David. HFDB, headed by Director Maria Teresa Vera, has three divisions, including the Policy Planning and Program Development Division, the Health Systems Development and Management Support Division, and the Facility Performance Management Division. Currently, the Patient Safety Program is under or lodged under the Policy Planning and Program Development Division. Our mandate as an office involves development of policies, programs, and strategies on health facilities, development, planning, operations, and management, provide coordination, technical assistance, capacity building, consulting and advisory services, as well as advising the Secretary and Undersecretary of Health on matters pertaining to the health facility development, planning operations, and management. When we talk about enabling mechanisms in the national level, we usually talk about three things. The first involves the policies that can be used to anchor the program. Secondly is the standards available that health facilities can use as a guide for implementation. And lastly, advocacies that would elicit stakeholder involvement in all levels. So looking into the policies, we will be discussing the highlights of two, which includes the AO on the National Policy on Patient Safety in Health Facilities, as well as the strategic framework for the adoption of integrated, people-centered health services in all health facilities. So as we all know, the Department of Health recognizes patient safety as a fundamental element of universal healthcare. In particular, there's a need to match our systems with the ever-evolving nature of health service provision. As complex procedure increasingly becomes the standard of care, there is also an increasing probability of error. Hence, systems must be in place to ensure patients and health workers remain safe and that quality care is accessible and continuously provided. Anchored on the UHC law and the call for the 72nd World Health Assembly on Global Action Plan on Patient Safety, the DOH is reaffirming its commitment to promote and integrate patient safety in health service delivery to improve health systems and outcomes. This is to ensure the alignment of the patient safety program to overall implementation of universal healthcare with the aim of preventing avoidable harm in prevention, diagnosis, treatment, and follow-up. The main objective of the administrative order is to provide guidance on the effective implementation and institutionalization of the patient safety program in all health facilities to improve safety in health service delivery, including that of the vulnerable population. The policy likewise emphasized the overall framework for the patient safety and looking into the importance of leadership and governance, organizational development, teamwork and communication, patient-centered care or people empowerment, healthcare worker safety, risk management, human resource development, and proper documentation and reporting as components of the patient safety program in all health facilities, with a center or with a focus on culture of safety and no blame culture, in the background of stakeholder engagement as well. The policy provided 6 strategies that can be implemented by health facilities. This includes Strategy 1 on operations and management systems, assessment of the nature and scale of harm, ensure competent and capable workforce, prevent healthcare-associated infection, implement key priority areas, and patient safety research. Aside from the patient safety policy, Administrative Order number 2020-0003, or the strategic framework for the integrated people-centered health services in all health facilities, highlighted the importance of promoting client engagement and empowerment by engaging patient groups in the development of policies. Usually, health facilities are being tasked to include patient groups in the development of the hospital policies they are creating under the Strategy 3 of the IPCHS framework. The next few slides looks into certain patient safety standards and some updates on where we are as the National Patient Safety Program. So in terms of standards, the policy provided the need for a committee and a safety officer in all health facilities. In 2022, the phase 1 of the organizational structure and staffing standards for level 3 government hospital was developed, incorporating a quality improvement, patient safety, and IPC unit where there's a dedicated nurse 5 position for patient safety. The approval of this unit and dedicated plantilla items for the patient safety as well as infection prevention and control will enable better implementation of the said program in the hospitals such as surveillance systems, incident reporting, and learning systems, conduct of performance improvement activities specific to key priority areas, and facilitate research from the reports generated from the program. In addition, updating the staffing standards to improve safe staff to patient ratio support a much safer environment for both healthcare professionals as, as well as safe staffing allows safe care. One of the initiatives of the Health Facility Development Bureau is treating patient safety as a cross-cutting standard across the different standards of care, standards of health facilities in the different departments. Usually, patient safety is being incorporated in the different manuals as a portion or a chapter so that we can integrate patient safety initiatives in the various parts of the health facility. The use of safety checklists has likewise been emphasized as part of the standards for ITC, as these checklists include surgical safety, safe childbirth, blood safety, and safe injections, among others. Just recently, the program circulated the use of the surgical safety checklist that the Philippine College of Surgeons tailored fit in the context of our country. The patient safety program likewise have been supporting health facilities in advocating the celebration for the World Patient Safety Day with the release of the new policy. In 2020, the theme was actually the health worker safety, priority for patient safety, with the slogan, Safe Health Workers and Safe Patients, with a call to action to speak up for health worker safety. In 2021, the theme was Safe Maternal and Newborn Care, and the call to action was for safe and respectful childbirth. And lastly, just recently and yesterday, medication safety as the theme for the 2022 World Patient Safety Day, with the slogan Medication Without Harm. So what do we expect from the National Patient Safety Program as we move forward and as we face the new normal? So just recently, a strategic planning workshop has been concluded for the program, and we finalized the following priority areas specifically for 2023 onwards. This includes engagement with stakeholders such as health facilities, local government, as well as the academe and non-government organization in implementing or supporting the patient safety program. We are looking also into developing a manual of procedures for patient safety that patient safety officers can refer to as they implement the policy as well as the program. We look into advocacy activities as well to empower patients, care providers, and healthcare workers, as well as focusing on capacity building for the patient safety officers by providing the basic course on patient safety that we will be expecting in the DOH Academy. And lastly, looking into evidence generation through research and the DOH data collect. Just recently also, we finalized the indicators that will be collected as metrics or measures for patient safety indicator or the patient safety program implementation. So before I end, I would also like to share the other systems, programs, projects, and databases being handled by HFDB. And for any inquiries or requests for technical assistance, you may contact us through the following contact details. We also have an existing website and YouTube channel as well as a Facebook page where you can be updated with the latest trends and policies related to health facility development. With that, maraming salamat po and have a nice day.
Thank you, TJ, for clearly articulating the mandate and future directions of the DOH in pushing for patient safety. Certainly, the recognition of patient safety as a fundamental element of healthcare should guide everyone in this room as we go about our tasks in our respective institutions. Dr. Antonio also mentioned earlier that the DOHAO on people-centered health services and health facilities encourages facilities and healthcare providers to provide environments to effectively engage and empower patients. So I think this nicely sets us up for the next part of the plenary, where our next speaker will talk about shared decision-making to engage patients and promote patient safety. Our next speaker obtained her BS Basic Medical Sciences, Doctor of Medicine, and Master of Science in Clinical Epidemiology in the UP College of Medicine. In the same college, she currently serves as professor, member of the Curriculum Committee, and chief of the Community-Oriented Medical Education or COME unit. She has numerous publications, innovations, and notable works on medical education, primary care, guideline development, health systems, and patient engagement, among others. She will now give her presentation on shared decision-making to engage patients and promote safety. Please give a warm welcome to Dr. Leah Eileen Palileo Villanueva.
Thank you, Diana, for that nice introduction. I'll now share my screen. Can you see my screen now?
Yes, thank you.
Okay. Thank you very much to the organizers of the Third Patient Safety Congress and Diana as the Scientific Committee Chair for inviting me to talk about how to engage our patients in their healthcare. I've titled my talk, Shared Decision Making, Our Patients, Our Partners. So these are my disclosures. As already mentioned, I practice and teach general internal medicine at the UPPGH, where I've been advocating for greater involvement of patients in healthcare and decision-making. I developed a module on shared decision-making, delivered several lectures on the same topic, and I've also conducted studies, particularly on developing patient decision aids. I've also participated in various trials and epidemiological studies that have received support from industry, professional societies, and public funding agencies such as the PCHRD and the Wellcome Trust in the UK. So for my talk, I will be covering what is shared decision-making. I will be defining shared decision-making and then discussing when shared decision-making is appropriate and how it can be done in clinical practice. And through the discussion of these three topics, I hope that we will realize how important shared decision-making may be in ensuring our patients' safety. So there are several models of decision-making available. No? So the first model, which a lot of us might be familiar with, is the paternalistic model. So in this model, physicians primarily or healthcare workers are considered the key driver of healthcare decisions. Patients are just passive participants, meaning they will just follow what the healthcare provider or the physician says about what is the best treatment option or best course of action to take in terms of the patient's healthcare. So that is the one end of the spectrum of decision making. On the other extreme of the spectrum is where is informed decision making, where the patient will take primary responsibility for making a decision about his or her care, and the physician or the healthcare team's role is really just to provide information for the patient to consider when making a decision about what the course of action would be best in terms of their healthcare problem. In both situations, there could be some problems. In the paternalistic model, where the doctor is king or the healthcare provider is king and makes all decisions, we run the risk of patients not receiving care that is consistent with what they value or what they want. So, or the risk of having patients take certain plans which might not be feasible for them, implement given their day-to-day realities. No? So that is the risk that we run if we follow the paternalistic model. On the other extreme, sometimes patients may make decisions that are not consistent with what is maybe best medical practice if we leave the decision making solely to the patient. No? So in recent years, no, not so recent, the model of shared decision making has come to fore. And how is shared decision making different from these two other models? In shared decision making, there should be at least two participants, and participants here may be individuals, for example, a physician, the healthcare team, and the individual patient, or groups, no? So the healthcare team, interprofessional team, as well as the patient and the significant others. No? And in this particular model, these two participants or participant groups engage in an exchange, a bidirectional exchange of information, and both parties deliberate together and negotiate what the best treatment option might be given the medical and clinical circumstances, as well as the patient's personal circumstances. And then after this shared or bidirectional information sharing, deliberation, and negotiation process, both parties come to a mutual decision about what steps to take given both information that is shared by both parties. So these are the three main components of a shared decision-making process. Now, it is a partnership between two participants, and there is equal sharing of information, reaching a mutual shared decision about the best steps to take in terms of the patient's health care. So why has shared decision making become an advocacy? No, why have we pushed for decision making? So shared decision making. Shared decision making through studies have shown that the process of shared decision making may lead to promotion of trust and honesty within the healthcare provider and patient relationship. No, because there is a mutual involvement and investment in the decisions that are made. It also helps patients address all their concerns because in this particular model, there is an active elicitation of patients' values, preferences, and concerns, no? Even those beyond the biomedical spheres, no? Whether it could include concerns regarding feasibility, depending on the daily circumstances of the patients. Even cost issues may be discussed in this particular model. So it really helps patients address all their concerns. The shared decision-making model also allows healthcare providers to get to know their patients better. Frequently in a medical or a consultation, healthcare providers focus mainly on health concerns, no, or the medical concerns of the patients. However, in the shared decision-making model, we go beyond the biomedical sphere, and this leads to healthcare providers getting to know their patients better, and hopefully being able to tailor the management according to the patient's realities. No? And ultimately, shared decision-making may improve the provider-patient relationship. In terms of outcomes, shared decision-making has been shown to increase patient satisfaction and the patient's knowledge of their disease, the patient's understanding of the different treatment options available to them, including the possibility of not doing anything for their particular condition. No? It may also lead to better adherence to advice and medications because there's already buy-in. The patient is involved in the whole process and the whole decision-making process, so there is already buy-in to the decision, and hopefully this would lead to better adherence. And lastly, although not consistently, studies have shown that shared decision-making may lead to better health outcomes. For example, diabetic patients or patients with diabetes who were offered various treatments, medications to start, no, because of their uncontrolled blood sugar, has led to patients actually choosing to start medications instead of just doing lifestyle modification. And this has led to better blood sugar control. Shared decision making has also led to a decrease in the use of invasive interventions such as PSA, prostate specific antigen testing for prostate cancer screening. And PSA has not been shown to be a good screening test for prostate cancer. So this has led to a reduction in the use of PSA screening in patients and resulting in better health outcomes and decreased cost of care. Okay. So really the aim of shared decision making is to engage patients to play an active role in the decisions involving their health. Its goal primarily is to elevate our patients to partners where there is an equal power between the healthcare providers and the patients. Okay. In the shared decision making, we need to acknowledge and realize that there are actually two experts in this conversation. So in recent years, especially with social media, this has become a commonly heard complaint among especially doctors, no? Now where patients come in with Dr. Google's advice, no? So this was a tweet by I found Trisha Greenhall. The doctor would usually get irritated or annoyed with patients who come in after having consulted Dr. Google because they feel like they have better expertise given their years of training. However, we need to realize that the patients have been living with their conditions for longer than maybe how long we've trained. So it's very important for us to acknowledge and accept that our patients are experts too. No, the healthcare providers are experts in the technical aspects of medical care, in the diagnosis of the condition, disease etiology, pathophysiology, treatment options, prognosis, and potential outcomes of particular treatments or interventions that we offer our patients. However, we need to acknowledge and accept that patients are also the experts in their own day-to-day experiences, in their personal circumstances, their social milieu, their values, preferences, and attitudes towards risk, all of which may have an impact on how healthcare is delivered and implemented, no? How they will adhere to medication, how they will understand and live with their conditions, as well as the treatments that we offer. So in shared decision making, this is a principle that we sort of live by, that our patients are also experts. And if we take this to heart, then this will really lead to person-centered care. I didn't place patient-centered care here because the patient is like limiting or reducing the person with the disease to just the disease. No? So we really need to consider that our patients are persons out and they have a life outside of being a patient. And that is what shared decision making tries to highlight or surface. So it is important that in shared decision making, it is not just sharing information. No? Although information sharing is a prerequisite, it is not synonymous to sharing a decision. No? So sharing decisions, the decision making itself, it involves more than just sharing information by the two parties. It involves deliberation and negotiation before the final decision about what is the best step, no? What is the best treatment for the patient is done. No? So how do we do this? No? So in shared decision making, both parties should participate in the process of decision making, which involves information sharing, processing, deliberation, and negotiation. However, we also frequently hear this, no? Especially among physicians, we say that, we try to involve our patients in decisions about their care, but our patients just don't want to participate. However, is it really that our patients don't want to participate? Or is it because being active is seen by patients as something that is not welcome by physicians, no? So especially in this age, no, we hear a lot of physicians. I'm sorry, my talk is focusing on doctors a lot of the time because I am a physician, but this may also be relevant to other healthcare practitioners. No, so being an active patient might not be welcome by physicians. No, so and this might hinder our patients from actively participating. Sometimes our patients also don't know that they actually have a choice, no, about what treatment to take. No, so for example, in situations such as osteoporosis, no, there are a lot of medications available for osteoporosis. They have all been shown to be effective, and they are all feasible and acceptable options. So it might be worth um, engaging our patients, no, asking them which of these options that they might want, because sometimes they don't know that they can actually choose. And if they don't know that they have a choice, then they will not participate in decision making. Other times, patients also need more information or skills in negotiation. Remember that there is a natural power difference or gradient between the healthcare provider and the patients. So sometimes patients might feel insecure about engaging their healthcare providers in a conversation or a dialogue about the best treatment course of action. And it's important that patients are trained in this particular skill. Physicians or healthcare providers also need some training in terms of engaging and encouraging patients to get involved in the decision-making process. In our culture, sometimes our patients just really just lack assertiveness. And so we need to offer this model or this option of being more involved in their care to them. And lastly, there are really some patients, despite being informed and in spite of being invited to participate, really just don't want to. No? But generally, when patients say, kayo na bahala, doc, or ayaw namin, no, kayo na mag-decide, we need to explore the reasons why and make sure that we do not involve them only when they do not want to. How about in the Philippines? What did we find? No, because that was that study was done in Western countries where we assume that patients are more active and more assertive. How about in the Philippines? So this study was done among patients consulting at the Philippine General Hospital. So we expect these patients to be from the lower socioeconomic strata, more socially or economically disadvantaged, and maybe with lower literacy. In preparing to develop this patient decision aid, we did some needs assessment through qualitative methods. And what did we find? Upon interviewing patients, they all unanimously said that they would participate if they were given the opportunity. And in terms of their experience, no, with their physicians, they said only some physicians spend time to discuss medication choice. And only a few of them actually ask their patients' opinions about their preferences on which treatment to take. Okay, so the patients in these interviews or in this focus group have also confirmed what we already have acknowledged in the past, so that family members, fellow patients, no, so hindi lang yung in immediate social circle nila, and even their healthcare providers as allies in decision making. So the group decision making with at least among this population is highlighted. How about among physicians? What do physicians think about shared decision making? So this confirms, so some physicians actually prefer to choose the medications for their patients. So some physicians really tend towards the paternalistic model of decision making. And some of the reasons for this is that there is a lack of time. They perceive that there is a lack of time to talk to their patients. They might have some limited knowledge. They feel that their knowledge on some options might be limited. And there might be limited resources given the workload in this clinic and the lack of time, the perceived lack of time. They also have a lower motivation to actually use shared decision making or to change their habits. They did say that they prefer to have visual aids that will help them engage their patients in shared decision making. In 2016, we also conducted a survey among patients, again at the PGH outpatient clinics, to find out how they perceive their involvement. Are they being involved in shared decision making? So in this questionnaire, the different steps in a shared decision making process were enumerated in the questionnaire, and patients were asked to what degree they thought these steps were being implemented for them. So what is striking here is that most patients actually agreed that all these steps were implemented or were being conducted by their healthcare providers. However, if you look at these three options, asking for the preferred option, negotiation, and coming to a shared decision, these three steps were actually found to be least conducted or performed by their healthcare providers. And these are the three key steps in shared decision making. So this tells us that there is still a lot of room for improvement in implementing shared decision making, at least in this setting. So how should we involve our patients in decisions about their health? First is to identify the decisions which are appropriate for shared decision making. So not all medical decisions or healthcare decisions need to undergo a shared decision making process. So only those preference sensitive decisions are recommended to undergo a shared decision making process. And what are these preference sensitive decisions? Preference sensitive decisions are situations when there are more than one treatment option that is acceptable to take, and there is no clear best choice. So for example, an example I showed earlier, I cited earlier, was the choice of osteoporosis. There are several medications available for osteoporosis, and they're all effective. And they each have their pros and cons. And the best choice is not very clear. So in that situation, it would be important to engage our patients in a shared decision-making process. Other examples would be maybe for screening, for example, breast cancer screening in low-risk patients, women. So sometimes deferring breast cancer screening, especially for younger women, might be an acceptable option because benefits for them might be very low. So in that situation, a shared decision-making process might be appropriate. So after identifying these decisions, the healthcare provider will need to inform the patients that the decision needs to be made, and then invite the patient if that patient wants to get involved in the decision-making process. When a patient, even if a patient does not want to be involved in the decision-making process, it is still important for the healthcare providers to discuss the available treatment options. And these are all the available treatment options that are acceptable and feasible, even doing nothing. So if doing nothing, meaning wait and see, is an acceptable option to take, course of action to take, then that also has to be presented to the patients. And then the harms and benefits of each option should be discussed in a way that is understandable to the patient. And during this discussion, we should welcome patients' questions about these options because this will allow them to gain more information, become more knowledgeable about the treatment options, and eventually this may lead to a better discussion and a better decision later on. While discussing the treatment options, it would be important to also in the process of discussing and negotiation, it would be important to clarify the patient's values and preferences. What are important to the patient? So it's not always the health outcomes that is the most important to the patients. Sometimes a health care outcome might be important to them, but daily a life issue is more important. So for example, some patients, although they are convinced for the need for an elective surgery, may have issues about the timing when it will be done. They might be hesitant to take that option because they have concerns about child care, who will take care of their children at home when they are at the hospital for surgery. So they might want to prefer the surgery to be done on a weekend because during that time they can tap other relatives to watch their children. So when we talk about clarifying patients' values and preferences, it is not just about the treatment options per se, but also other concerns outside of the biomedical or healthcare field. Lastly, when all these are clarified and all treatment options have been explained well, then both the healthcare provider and the physician and the patient come to a decision together. And this decision may be taking one of the treatment options and implementing one of these treatment options, or waiting. No? So sometimes our patients might not yet be ready to make a decision, or they might want to consult with other significant others, and that is an acceptable result of the shared decision-making process. So the shared decision-making process ends with the decision that is made, and this can be doing nothing. What is important to highlight here is that shared decision is one where both parties agree to the decision and share responsibility for it. So hindi yung bahala na yung patient or bahala na si doc. It's a negotiation and a mutual agreement. And because it is a mutual agreement, both parties take ownership of that decision and share responsibility for it. There are certain tools that help facilitate this decision-making process. And some of these tools are called patient decision aids. So these are designed to help patients make very specific and deliberated choices among the different healthcare options. And there are different designs, formats, no? So there are online, multimedia, paper-based patient decision aids, videos, etc. And they have also been designed to be used before a consultation to prepare a patient to discuss with their healthcare providers, during the consultation to facilitate conversation, encourage and facilitate conversation, or even after a consultation to help patients mull over the different options and discuss with their significant others. Okay? And these decision aids, a lot of studies have been done on various decision aids covering a broad range of diseases. And what have they shown? No? So patient decision aids have been shown to be effective in increasing the knowledge of patients about the disease and the various treatment options. Patients, after a shared decision-making process using a patient decision aid, have more accurate perceptions of the risks involved, both for the various treatment options as well as doing nothing. Patient decision aids have encouraged patients to become more active, and these have resulted in better decision quality, meaning patients are satisfied with their decision and they do not feel regret about their choice of treatment options. Locally, we have developed some decision aids, one on osteoporosis, no? And this decision aid was designed as a paper-based decision aid, which is used during the consultation, and it includes some sort of worksheets. And this decision aid was acceptable to both physicians and patients because it stimulated conversation. For patients, they felt that the decision aids made the options clear for them. They appreciated that cost was included in the discussion, and they liked that it was graphical, no? And then they liked that the information shared with them was personalized through a worksheet. On the other hand, doctors felt that this decision aid helped them elicit what is important to their patients. It helped them provide evidence-based information. It also served a guide for explaining the different options and the evidence to their patients, and they liked that it was more interactive. We also designed a similar decision aid for use among patients with diabetes who still have uncontrolled blood sugar and would need to choose an add-on medication. The median duration of the consultation was only about 9 minutes long. So it really didn't extend the consultation time too much. However, for a low literacy older patient, it reached up to 25 minutes. And majority of patients felt that they gained knowledge and there was an improvement in the shared decision-making process, at least as perceived by patients. There is also another patient decision aid, this time an app, that has been developed again among Filipino patients. And again, this was acceptable to both physicians and patients. And there was a reduced decisional conflict, meaning the uncertainty about what is the best decision to take among patients was decreased, and there was improvement in patient knowledge. Okay. So there is an inventory of various decision aids available. I know this is in Ottawa, so this is in Canada. A lot of these were developed in other countries, but we can certainly try to use some of them if we want to, or adapt them to our setting when we discuss with our patients. It is also important that to realize that training is required not only for patients, but even for healthcare providers. And these are some training resources that we can use, or we can tap to help us develop our shared decision-making skills. So in summary, I've defined what shared decision-making is. It is a collaborative approach to medical decision-making that involves two experts or expert groups, the healthcare provider and the patient. It is a skill that can be developed. And so we need to start thinking about including it in training, not only of our students, but even for continuing professional development. And there are tools to support shared decision-making. In the country, there is a lot of room for research in developing such tools. And lastly, shared decision-making leads to person-centered care. I'd like to end with this quote that I read online. We need to remember that ultimately the patient isn't a disease with a body attached, but a life into which disease has intruded. Through engaging the patient voice, we have a powerful tool to inspire and shape new solutions in healthcare. As the healthcare system takes a more collaborative approach to helping patients, and as patients become active participants, which is really the aim of shared decision-making, everyone wins. Thank you very much. I will end my talk here, and I would be happy to answer any questions later on. Thank you for your attention.
Thank you, Leah. I know everyone will agree with me when I say that Leah has effectively introduced us to the important concepts and steps in implementing shared decision-making and its impact on promoting patient safety. I hope all of us here in the Congress can utilize the strategy and recognize the other expert in the conversation, as Leah mentioned, our patients, that's our other expert in the conversation, as we formulate and implement our healthcare plans with them. All right. So we have, again, I think we've already some of our speakers already have answered the questions in the Q&A box. So I enjoin everybody, all of our attendees, to still put in their questions in the Q&A box. And our speakers will be very happy to answer your questions in the Q&A box. Thank you very much again. Now we want to hear from the most important stakeholder in patient safety, our patients. Our next speaker will share her expertise and insights on the topic patients and families as partners in safety. Maria Fatima Garcia Lorenzo is a certified child life specialist and is a member of the Association of Child Life Specialists in the USA. She completed her child life internship at the University of California, San Francisco Hospital. She finished her graduate studies on child and family psychology at the Ateneo de Manila University. She is a Philippine licensed child and family psychologist. She is the co-founder of the Kite Foundation and co-founder and past president of the Philippine Alliance of Patient Organizations. Let us welcome our final speaker for this plenary, Ms. Maria Fatima Garcia Lorenzo.
A good day to our distinguished panel of speakers and to our participants. Thank you so much for inviting me to this conference. I will now share my slides. The Philippine Alliance of Patient Organizations, or PAPO, is a coalition of patient organizations advocating for universal access to health care and allied services, and is a member of the International Alliance of Patient Organizations. We aim to empower Filipino patients, including persons with disabilities, through education, networking, policy advocacy, and capacity building. PAPO advocates for meaningful reform in three fundamental areas in order to improve the quality of healthcare in the country, namely respect for patients' rights, universal health care, and patient participation in health policy making. Why must health facilities and their teams collaborate with patients and their families? There are two policies that support patient engagement. The Department of Health issued Administrative Order 2020-007 on 11 February 2020, which was signed by then Secretary Francisco Duque. Under the section on patient safety standards in the health facility, it stated that all health facilities shall have a patient safety unit or committee with a designated patient safety officer to oversee and manage the patient safety program. This shall be composed of members from those with a permanent or regular appointment, auxiliary members as deemed necessary, and patient partners from patient groups. In addition, the WHO Global Action on Patient Safety in 2019 encouraged member states to implement systems for the engagement and empowerment of patients' families and communities, especially those who have been affected by adverse events, in the delivery of safer health care, including capacity building initiatives, networks and associations, and to collaborate with them and civil society in order to use their experience of safe and unsafe care to build a culture of safety. How do we forge partnerships with patients and families in improving safety in health facilities? Communication. Communication is the basis of partnerships between the patient, family, and clinicians, and it affects the safety and quality of care received during hospitalization. What is the evidence linking communication with safety and quality? One, in review of literature, it was found that engaging patients and families through effective communication had a positive effect on patient outcomes, specifically emotional health, symptom resolution, functioning, pain control, and physiologic measures such as blood pressure and blood sugar levels. Two, one study found that more than 70% of adverse events are caused by breakdowns in communication among caregivers and between caregivers and patients. Studies show that patients who are informed and engaged can help improve patient safety through informed choices, safe medication use, infection control initiatives, observing care processes, reporting complications, and practicing self-management. 3. Research demonstrates that patients' and family members' perceptions of quality are influenced by their perceptions of their interpersonal interactions with clinicians and hospital staff. Clinicians who are perceived to be responsive and attuned to patients' needs are judged to be of higher quality by patients than clinicians who are perceived to be less responsive, even if the clinical care provided is the same. Now, what are some communication obstacles for the patient and family? 1. They feel unsure or intimidated about contributing to their care. Patients and family members may feel uncertain about how to participate or are intimidated by clinicians, hospital staff, and the healthcare system. If clinicians use professional or medical jargon, the patient and family may be particularly intimidated. 2. There is a need for more information to be full partners in their care. Clinicians can help increase the patient's and family's awareness and confidence in taking part in the patient's care by giving them information about the patient's condition and next steps regularly through the hospital stay. Information is most helpful when it addresses the patient's and family's individual's needs and concern. Number 3, there is a need for an invitation and reinforcement from clinicians. Although information is necessary, it is not sufficient to support behavior change. The patient and family will need support and reinforcement from clinicians to engage in their care. Patients are more likely to take part in their care when clinicians encourage them to ask questions, respond positively to the patient's needs and views, and give patient the information they need. On the other hand, what are the challenges in communication for clinicians? Clinicians may believe they are already communicating effectively or may not know how to implement new communication strategies. Instead of focusing on communication, clinicians may wish to concentrate solely on the clinical aspects of quality care, such as their skills in diagnosing, treating, and achieving favorable clinical outcomes. Although many clinicians recognize the importance of communication as a component of quality, their perceptions of how effectively they communicate tend to be overly optimistic. Even when clinicians recognize the need for improved communication and patient-centered care, it may be challenging to implement new skills and behaviors. Traditionally, professional culture and practice norms have prioritized technical skills over communication skills. Traditionally, professional culture and practice norms have emphasized individual autonomy over teamwork and patient-centered practices. Clinicians lack experience with models that encourage patient and family collaboration. Traditionally, professional schools such as medical schools and academic programs that train healthcare leaders have placed little or no emphasis on patient and family engagement. Three, clinicians may be concerned about family interaction. Concerns associated with family presence include the possibility of treatment interference, medical risk, and the emotional reaction of the family member. Clinicians may also be unsure of how to proceed when the patient and family desire different treatment approaches. It is essential, therefore, that your hospital identify the communication challenges that are most likely to arise in your environment and devise strategies to overcome them. Aside from reviewing communication strategies, how else can healthcare institutions establish partnerships with patients and their families? The American Institute for Healthcare Improvement convened the National Steering Committee for Patient Safety and developed a national action plan to improve patient safety. The National Action Plan focuses on four interdependent and foundational areas that the National Steering Committee deemed essential for the safe development of total systems. And these are cultural leadership and governance, patient and family engagement, workforce safety, and learning system. Patient and family engagement is defined as the dissemination of genuine patient and family engagement, the practice of co-designing and co-producing care with patients, families, and care partners to ensure there are meaningful partnerships in all aspects of care design, delivery, and operations. Additionally, the Institute for Healthcare Improvement National Steering Committee for Patient Safety developed a self-assessment tool for their national action plan to advance patient safety. As a guide for forming partnerships with patients and families, I'd like to share this resource with you. For the purposes of my talk, I will focus specifically on patient and family engagement and describe the criteria which merits a perfect score of 4. As I go through the tool, I hope you can assess if the criteria is applicable or not applicable to your institution. Number 1 is Patient and Family Advisory Council. You get a perfect score of 4 if your organization has an actively engaged patient and family advisory council. And if senior leaders ensure the PFAC informs an organization or system-wide strategy and measurement plan for patient engagement that includes patient and community representation on all boards and committees, event review processes, and improvement initiatives. Second, patient care co-design. A perfect score of 4 means all clinicians fully involve patients in their care, including use of what matters to you questions, checklists, and shared decision-making tools, and all huddles and shift changes are completed at the bedside. Next, training and resources. The organization gets a 4 if it provides safety and patient-provider communication training and resources to all patients, clinicians, and staff. These educational materials are available in the preferred language and appropriate literacy level for each patient. Next up, we have patient portals. You get a perfect score of 4 if patients have access to their medical records through an online portal. There is an organization-wide program to raise awareness about patient ability to access their medical records, and advisors are available to assist patients as needed. Next, we have equity. You get a perfect score of 4 if the organization segments and reviews all adverse event data and patient experience feedback by characteristics such as race, ethnicity, sexual orientation, gender, age, disability, and income. And if senior leaders regularly review identified gaps and action plans to address health inequities are developed and executed. If all leaders, clinicians, and staff receive training in health equity and unconscious bias. Next, communication and resolution for adverse events. You get a 4 if the organization has a communication and resolution program and a staff training plan in place to respond to adverse events. Support programs are available for patients and families, clinicians, and staff who are impacted by these events. The program is regularly reviewed by senior leaders and the board. Last is escalation pathways for safety events. You will garner a score of 4 if patients have the ability to report safety events into a patient safety database, and there is a structured system for patients and families to escalate concerns about their care through the use of rapid response team or other structured response mechanism. The organization regularly reviews and responds to safety events that have been raised by patients and families. On this instrument for self-assessment, I have no doubt some of the healthcare facilities represented here in this conference earned high remarks. Congratulations. Now, you might want to consider sharing your organization's most successful procedures and best practices with those other medical facilities that are now starting to develop their patient safety programs. This could be a possible step moving forward. And speaking of taking other steps in the right direction, I'd like to urge our health leaders to take a more proactive step in creating an enabling environment for health institutions to have meaningful engagement with patients and families. Let us begin by updating the Patient Safety Manifesto from 2015. The patients and families hope that the revised manifesto will include a clause that recognizes them as equal partners in the patient safety process. A special shout out to patients and their families. Let us be aware of our rights and responsibilities. Let's do our part to increase health literacy and enhance our communication skills so we can participate in patient and family advisory councils and other health policy making bodies with confidence. I hope I was able to give our participants valuable information on how to forge partnerships with patients and families in improving safety in health facilities. I look forward to an engaging discussion during the plenary. Thank you very much.
Thank you, Ma'am Girly. I think we cannot overemphasize the crucial role of effective communication in fostering mutual trust and sustained partnership with patients, as you have pointed out. I eagerly anticipate that the leaders and healthcare staff here reflect on their need to assess how their facility is able to promote patient engagement and to urgently act on what they found from the said evaluation. I hope we can help Map Girlie's call to our patients to be more aware of their rights and be more proactive. Let's help her, no? Ano natin yan, spread the word natin yung call for action ni Ma'am Girlie. Thank you so much, Ma'am Girlie. And thank you for our speakers. We don't have an open forum, but the questions in the Q&A box have been answered adequately and very nicely by our speakers. And I join everyone in thanking our panel of speakers for the excellent plenary. As we close our scientific sessions in the Congress, let me speak in behalf of the organizing committee in expressing our gratitude to all our speakers, session chairs, and attendees, and to also express our enthusiasm that the plenaries, the simultaneous sessions, and the discussions have been relevant and enriching to all of you. For the next part of the program, I will call on the chair of the Abstracts Committee, Dr. Carlos Miguel Perez, to announce the winners of our oral video, e-poster, and advocacy video competitions.
Thank you, Dr. Lachica. Good morning to everyone. But before I announce the winners, I'd like to make mention of the process involved in coming up with the top abstracts. No? So out of the 100 of abstracts submitted, before, what we have before us, what you can see in the website, what you watched earlier, are those who passed a very stringent screening process. So on that regard, I think all of them are already winners. So it is my opinion that you did your institution yourself. You did your institutions proud in coming up with excellent abstracts. So on the next slide, we'd see a few reminders. So for the winners, Jen Pagyo would personally email you, regarding how we go about giving you the small token, the prize for that matter. And the following slide just shows the token I am speaking of. So the oral presentations, the monetary token is as follows. For the electronic posters posted on the website, these are the corresponding prizes. As well as for the advocacy videos. I think these were also posted on the social media. So without further ado, I'd start with the oral presentations, the oral abstract presentations. So third place goes to Christine Javier for her abstract on healthcare-associated infections, HAI Goodbye, bloodborne pathogen exposure prevention program. Christine, congratulations for winning third place. Second goes to Julius Vinluan for the abstract Transforming Nurses in the New Normal, Progressive and Alternative Competency Enhancement Initiative. Congratulations. First place goes to Dr. Mark Velasco, and of course the Department of Anesthesiology for the narcotics disposal algorithm. Congratulations, Dr. Velasco. For the poster presentations, this was quite interesting in that there was a computational tie, no, for third, no. So I'd be mentioning the third place first. So Mr. Mark Ryan Portugues with his abstract on medication safety practices among older adults. Congratulations for winning third. And he shares this prize with Dr. Jose Magno, no, for his paper on the interim guidelines for enhanced quality and safety at the echocardiography laboratory amidst the emerging infections. So congratulations for you both. No, you won third place. Second place for the electronic poster goes to Dr. Panganiban with her abstract on assessment of patient safety culture in randomly selected hospitals in the Philippines. Ma'am, congratulations. And first goes to use paper on professional quality of life and workplace psychosocial support interventions among nurses in the Philippines during the pandemic. Congratulations, Johan. For the advocacy videos, now what was interesting in this was that apart from the judging criteria we gave our expert panel, no, a weight of the scoring was from the engagement in our social media websites, no. So again, it's a new way of adding to the judging criteria. So without further ado, third goes to the Philippine General Hospital. No, it's a joint effort between doctors, nurses, and everyone, all stakeholders, with their video entitled "Together We Are Better, Stronger, Safer. Together We Are Patient Safety." Congratulations to PGH. Second goes to Jem Gacias for her video entitled "Shift Safety Huddle." And first goes to Revi Ayala on the video entitled "Stewards of Antimicrobials in Northern Luzon." So congratulations to all. Reminders, no. Again, the organizing committee would contact you, no, regarding claiming your prizes. And second, no, I'd like to invite everyone to still view all entries, not just the winners, no. You can view all 10 e-posters and all 6 advocacy videos. No. Again, congratulations to the winners and congratulations to everyone. Thank you and good morning. So I give the floor back to Dr. La Chica for the pledge of commitment. Thank you.
Thank you, Miko. And congratulations again to all our winners. Special mention to my team, Ma'am Lynn. Congratulations, ma'am. All right. So let's go now to the pledge. As you know, the Patient Safety Congress pushes for policy and practice changes to ensure the alignment of safeties for human resources for health aimed at creating a positive impact on patient and worker safety. As such, we not only designed scientific sessions to create such an impact, but would like to use this platform as a call for genuine action. And that is why we have shared with you all and wanted to encourage everyone to sign this pledge of commitment. And you can see from the screen that you can still access it through the link, or you can scan the QR code. No? As of this moment, we have 530 people who have signed the commitment to patient and health worker safety. I think it starts here and hopefully it continues to as we move back and go back to our institutions and as we go about our work, and this guides us throughout our entire year or years until we see each other again and look to ourselves on what our commitment has been and what our actions have been, no, from the last year. So with that, and hope you all have gone through this, let us now, hopefully everybody's here, you can join in. And I enjoin everyone to now to proclaim this pledge of commitment to patient and healthcare worker safety. So the pledge starts: we, partners for patient care and advocates of both patient and healthcare worker safety, recognize the following: that the health and safety of both patients and healthcare workers are priority public health concerns and are crucial to the achievement of the quadruple aim in healthcare. That amid growing demands in healthcare brought about by current and emerging global health challenges, there is a need to craft systemic interventions to promote patient and healthcare worker safety. Next. And that amid growing demands in healthcare brought about by, and that interprofessional and multi-stakeholder collaborations are key in effectively addressing health and safety concerns of both patients and healthcare workers. Therefore, to achieve the Sustainable Development Goals on good health and well-being, quality education, and decent work and economic growth, we commit to the following: to advocate for environments where workers have physical and psychological safety from harm, neglect, and disrespect, and where joy is fostered in the workplace. We also want to advocate for policies, standards, and frameworks that promote patient and healthcare workers' safety. To promote the conduct of research on patient and healthcare worker safety and its use on evidence-based policymaking, and to promote strategies towards effective teamwork and mutual trust in facilities and communities. To collaborate towards implementing programs that equitably foster health worker safety. To collaborate towards developing interdisciplinary competencies and supporting interprofessional education and training for integrated care. To collaborate towards forging strong partnerships with our patients, our full partners in care and their families. Proclaimed the 17th of September 2022 virtually at the UP Manila, Philippines. Thank you, everyone. I think so far now we already have 566, and I think this bunch of 566 and I think more individuals is a glaring beacon to everyone after this, that we will continue to advocate for patient safety, use what we've learned from the Congress and what we have learned from each other, and continually support each other, and most especially our patients, in giving safe and quality healthcare. Thank you very much.
Thank you, Dr. Diana Lachica, for the pledge of commitment to patient and health worker safety. We are nearing the end of the Congress. To give the closing remarks, may I kindly call on Dr. Armando Crisostomo, Honorary Chair of the Third National Patient Safety Congress. Let us give him a virtual round of applause.
Pleasant day to everybody. My closing remarks will be highlighted by words that begin with a key letter, and that is the letter P. First of all, let me express that it is a P, pleasure, and P, privilege on my part to give the closing remarks and serve as honorary chair of this highly successful Congress. This all started more than 2 years ago in the planning, when after finishing her PhD in nursing in Hong Kong, Professor Jen Paggi of the College of Nursing returned home to the Philippines. In our very first meeting with her, I broached her the idea of organizing this third Patient Safety Congress, using as theme the synergy or interaction or need for us to focus on healthcare worker safety aside from patient safety. Coincidentally, within a year of that event, And that is during Patient Safety Day last year, or exactly a year ago. The WHO issued a charter that called on governments and healthcare leaders to address persistent threats to the health and safety of health workers and patients. Let me quote from Dr. Tedros Ghebreyesus, the WHO Director General, who said that the COVID-19 pandemic has reminded all of us of the vital role health workers play to relieve suffering and save lives. Quote, no country, hospital, or clinic can keep its patients safe unless it keeps its health workers safe. The WHO Safety Charter is a step towards ensuring that health workers have the safe working conditions, the training, the pay, and the respect they deserve. End of quote. Let me say that it is not logical and prudent to talk about healthcare worker safety because they are personnel and patients. P, personnel and P, patients are both P, people. And when you have programs that make people the center or focus of your care and attention, we can never go wrong. I'm sure this conference has highlighted a lot of potential problems that continue to exist. That's another P, problems. But instead of looking at them as problems, let us look upon them as another P, potential. Potential to prioritize and the potential to establish P, partnerships with all stakeholders so that we together can ensure the safety of our patients by taking care of the healthcare workers who provide for them. So with that, I'd like to congratulate the organizing committee headed by Professor Jennifer Paggio, the organizing committee, and all of the participants. Based on our last count, I think we had more than 3,000 divided into the 3 tracks. Your interest in this Congress, I'm sure, will go a long way, and I hope that when you return to your respective healthcare facilities, you carry on the torch of pushing for reforms that will improve the working conditions of healthcare workers in your respective area. Because that is one of the best ways we can ensure that our patients are kept safe and free from harm and adverse events. Again, thank you for this opportunity.
Thank you, Doc Arman, for closing the 3rd Patient Safety Congress.
We would like to thank the tireless efforts of the organizing committee of the 3rd Patient Safety Congress. Overall Congress and Secretariat Committee, for the Chair, Dr. Jennifer T. Paggio. Co-Chair, Dr. Lenora C. Fernandez. Honorary Chair, Dr. Armando C. Crisostomo. Presentation Committee, for the Chair, Ms. Frances Louise U. Mo. Scientific Program Committee, for the Chair, Dr. Diana R. Tamandong La Chica. For the Abstract Committee, the Chair, Dr. Carlos Miguel P. Perez. For the Social Media Publicity and Promotions Committee, for the Chair, Dr. Iris Tiel Isipdan.
So that wraps up our 2-day Congress. Please do not forget to answer our evaluation form. Receive your e-certificate after the event.
Thank you very much for attending the third National Patient Safety Congress, Synergized Approach to Patient and Health Worker Safety. Have a great rest of the day.
You